Test 1 2. Check 1 2.
This will be. Okay, can you hear me? 1, 2, 3, 4. Okay, thank you, man. Bye, man. Okay, okay. You need a mic check? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Temporarily, can you just plug it back in? Put it in under that desk.
So I did see your email last night. That was the only company that seemed to have a better rate right now. So yeah, and everything on my job is moving. Yeah. How's your morning going? Not enough. Not enough. Is it because of the pet? Oh no, there's so many extras. Yeah. Yeah. No, they make things less, but no, just volunteering. Well, that helps for the day healthcare announcement. Yeah, that too. So it's like now or ever, so like what's going on? So obviously as soon as it comes up to you. Yeah. Well, if you need anything, just let me know. We're like, yeah. Nice to meet you.
Ms. Mike, Budget Committee, check one.
I know my colleague Allie was out here earlier, so I'll make sure you guys have this credit as well. You will be filling out this form of Article 3 for the second extension. Anything else, either Allie or I should be here for whichever was ready. On the 17th, too. A lot of healthcare systems. Yeah.
Testing 1 2 3. Testing 1 2 3. Audio check 1. Audio check 2. Test 1. Test 2. Checking 1. Checking 2. Test test test.
This hearing on the HHS FY 2020 budget. I'd like to welcome Deputy Secretary Eric Hargens, and thank you for joining us. Today, I'm yielding myself now 5 minutes for my opening statement. Today, we will discuss the President's 2020 budget for the Department of Health and Human Services and its impact on American families. There are many concerning parts of the administration's proposal, but the budget for HHS is particularly troubling because the line between massive funding cuts and severe consequences for American families, between policy changes and life or death outcomes, is so direct. The Trump budget cuts more than $12.1 billion from HHS's discretionary budget, $4.5 billion from NIH, which includes research on the prevention, treatment, and care of diabetes, cancer, heart disease, Alzheimer's, and nearly every other disease or disorder facing Americans. It embraces austerity-level spending caps and the resulting cuts to healthcare investments, even though these caps have been repeatedly rejected by Congress on a bipartisan basis. The budget also cuts $1.4 trillion from mandatory healthcare spending, including Medicare and Medicaid, which are the only sources of healthcare coverage for tens of millions of Americans. The budget repeals the Affordable Care Act and replaces it with an inferior plan that would leave millions of families without meaningful insurance while failing to continue guaranteed protections for people with pre-existing conditions. It ends the Medicaid expansion under the ACA, terminating health coverage for millions more. In my home state of Kentucky, with a total population of just over 4 million, nearly 500,000 people gained health care coverage thanks to the ACA's Medicaid expansion. All this before the administration's abhorrent decision last night to ask the Fifth Circuit to completely invalidate the Affordable Care Act, making it crystal clear to the American public that this president has zero interest in protecting their health care in any form. The budget also converts base Medicaid funding into a block grant or per capita cap. This will force states to eliminate or drastically reduce services for low-income children, people with disabilities, and seniors, or, in the alternative, to raise billions of dollars to cover the loss of federal resources, which we all know states don't have. In addition, the budget requires all states to implement work requirements for Medicaid enrollees, putting yet another barrier between Americans and quality health care. In Arkansas, this wonderful home of my ranking member, which implemented the first work requirement in the country last year, more than 16,000 people have already lost their health insurance with no evidence that they found new employment. Expanding this policy nationwide would undoubtedly result in hundreds of thousands, if not millions, of Americans losing their health care coverage. Deputy Secretary Hargens, it is clear that this budget jeopardizes the health care security of millions of Americans and their families. So it is hard for me and my Democratic colleagues to understand how that meets HHS's mission to, quote, enhance the health and well-being of all Americans, unquote. Given the severity of the funding cuts and the extreme nature of the policy changes, this seems much more like an irresponsible way of offsetting our Republican colleagues' deficit-financed tax cuts for millionaires and big corporations than a true budget you or Secretary Azar would have crafted for your agency to succeed. I hope to discuss that further today. There are some other areas of the budget that don't add up either, where the message doesn't match the math. For example, the budget includes a $291 million investment in HIV/AIDS, but cuts the National Institute of Allergy and Infectious Diseases, which is responsible for most HIV/AIDS research at the National Institutes of Health, by $769 million. The budget provides an additional $50 million for pediatric cancer research, sounds good, but cuts funding for the National Cancer Institute by $897 million. The budget requests $1.5 billion for state opioid response grants, again, something I think we all favor, but it cuts Medicaid, the source of coverage for 4 in 10 adults with opioid addiction, by $1.5 trillion. When you compare these small funding increases to the large cuts they are paired with, it's not hard to see them for what they are, token investments designed to get a good headline. If there is another explanation, Deputy Secretary, we would welcome it. I know my Democratic colleagues have other questions about the choices made in this budget and the resulting consequences, about promises made by the President that are broken in this document. We want to know more. So once again, thank you, Deputy Secretary Hargan, for being here today. We look forward to your testimony. I now welcome and recognize the ranking member for 5 minutes for his opening statement.
Apologies for running just a little bit late. But thank you, Mr. Chairman, and thank you, Deputy Secretary Hargan, for joining us. Today, we're here to examine the President's budget request for the Department of Health and Human Services for fiscal 2020. This is an important conversation. Your agency is responsible for administering programs on which millions of Americans rely, including Medicare, Medicaid, Temporary Assistance for Needy Families, or TANF, Head Start. Further, your agency is at the forefront of combating some of our country's biggest health crises, including the opioid epidemic, which claims the lives of 115 Americans every day. Now, let's put that in context. Assuming we're here for 2 hours this morning, 10 people will die because of this epidemic. The growth in spending has been caused by several factors that require our attention in Congress. Healthcare spending is growing faster than any other sector of the economy. In 2017, U.S. spent $3.5 trillion on healthcare. By 2027, healthcare spending is projected to reach nearly $6 trillion, just under 20% of GDP, according to a recent report from the Centers for Medicare and Medicaid Services actuary. The cost of care is increasing. According to Bureau of Labor Statistics, in 2018, the price of hospital services increased by 3.7%, price of medical care by 2%, both of which were higher than the rate of inflation. The second contributing factor, Americans are living longer. Thanks to advancements in modern medicine, average life expectancy has increased by more than 9 years since Medicare was created in 1965. It is projected to continue increasing. That's good news, but it does have an impact on growing healthcare spending. Finally, the ratio of retirees to workers is shrinking, with an average of 10,000 baby boomers a day leaving the workforce. Unfortunately, the laws governing how our healthcare programs work do not reflect the dynamics we face today. As a result, there's increasing pressure on programs like Medicare, which today provides care to about 15% of our population. As an example, Medicare Part A, which covers inpatient hospital care, skilled nursing facilities, hospice, and lab tests, is expected to be insolvent by 2026, threatening the health benefits many expect to receive in the future. 2026, that's just 8 years away. Congress and the administration together have a shared responsibility to address these challenges and put our health care spending back on a sustainable path. That requires taking a hard look at what's working and what's not. It requires the courage to make tough choices that preserve and strengthen programs for Americans today and in the future. The President's budget takes important steps to do just that, investing in the long-term health of the American people while also advancing proposals that will help rein in healthcare spending. For example, the President's budget continues historic funding to fight the opioid epidemic by expanding access to prevention, treatment, support services, and research. This includes efforts to prevent improper or abusive prescription practices that have dangerously and unnecessarily exposed patients to opioids. It also aims to dramatically decrease the number of people affected by HIV, with the goal of reducing new infections by 90% within a decade. At the same time, the budget includes several common-sense reforms that have been proposed by Republicans and Democrats to make Medicare work better for patients by cutting waste, fraud, and abuse, increasing competition, and lowering drug prices and out-of-pocket costs. All told, these efforts achieve roughly $1 trillion of savings in mandatory spending. That's important progress. But with $22 trillion in debt and annual deficits nearly $1 trillion, there's much more work to do. As I've said before, mandatory spending accounts for 70% of all federal spending, and the glide path we're on takes it to 78% by 2029. Until we make structural reforms to mandatory spending like Medicare, discretionary spending, including funds for defense and border security, will continue to feel the squeeze, and Congress will continue to have the same battles year after year over what programs to fund and how to handle our debt. I'm fearful that my colleagues on the other side of the aisle may double down on this approach, proposing ideas that will make our nation's grim fiscal reality even worse. We've already seen a proposal that would radically disrupt our healthcare system, adding trillions of dollars to our national debt while eliminating patients' choice and raising taxes, and there's no plan to pay for it. We have a responsibility to put forward serious solutions, not catchy slogans, to improve our healthcare system and rein in spending. I look forward to hearing more from the Deputy Secretary this morning as we work through these questions in Congress. And with that, Mr. Chairman, I'm proud to be here, and I yield back my time.
I thank the ranking member, and in the interest of time, if other members have opening statements, you may submit those statements in writing for the record. Deputy Secretary Hargan, the committee has received your written statement, and it will be made part of the formal hearing record. You will have 5 minutes to deliver your oral remarks, and you may begin when you're ready.
Thank you, Chairman Yarmouth and Ranking Member Womack. Thank you for inviting me here to discuss the President's budget for HHS for fiscal year 2020. It's an honor to be here today, and it is an honor to serve as Deputy Secretary of HHS. The men and women of HHS delivered remarkable results since the release of our last budget, including record new and generic drug approvals at FDA, the beginnings of a sea change in drug pricing behavior, opening up new, affordable, personalized insurance options, and initial signs that the trend in drug overdose deaths is beginning to flatten and decline. The budget proposes $87.1 billion in FY 2020 discretionary spending for HHS, while making important reforms to help our discretionary and mandatory programs work more effectively and efficiently. While this budget delivers on our mission, it is important to realize that HHS had the largest discretionary budget of any non-defense department in 2018, which means that staying within the cap set forth by Congress has required difficult choices about the investments we make. Today, I will highlight some budget proposals around 4 priorities Secretary Azar has identified for the department: increasing the affordability of individual health insurance, bringing down drug prices, transforming our healthcare system into one that pays for value, and combating the opioid crisis. First, the budget proposes reforms to help deliver Americans truly patient-centered affordable health care. It would empower states to create personalized healthcare options that put the American patient in control and ensure he or she is treated like a human being, not a number. That means giving more responsibility back to states and increasing options for patients, while promoting fiscal responsibility and maintaining protections for people with pre-existing conditions. Second, the budget supports access to affordable prescription drugs through the 4 pillars of the President's drug pricing blueprint: more competition, improved negotiation, better incentives around list prices, and lower out-of-pocket costs. The budget will boost competition through fostering efficient approvals of generic drugs and biosimilars, anti-competitive practices, delaying or restricting these drugs' market entry, and reforming incentives to increase their adoption. The budget proposes a historic modernization of Medicare Part D to lower seniors' out-of-pocket costs, improve incentives for Part D plans that negotiate on their behalf, and save money for the program. Third, President Trump is focused on the broader goal of delivering Americans better care at a lower cost. This means ensuring our federal health programs are driving value for patients and living up to the promises that we've made to our seniors. The budget proposes a value-based payment system for hospital outpatient departments and ambulatory surgical centers, expands site neutrality in payments, reduces burdens on providers, and addresses overpayments to post-acute care facilities. These reforms will mean lower costs for seniors and a stronger, more sustainable Medicare program. The budget in total will extend the life of the Medicare Trust Fund by 8 years. As you all know, the administration has worked with Congress to make historic investments to address our country's opioid crisis, a crisis that years ago hit the town I grew up in and has struck my own family. The budget fully supports HHS's 5-point strategy to improve access to prevention, treatment, and recovery services, to better target the availability of overdose-reversing drugs, to strengthen our understanding of the crisis through better data, to support research on pain and addiction, and to improve pain management practices. The budget provides $4.8 billion towards these efforts. This investment builds on appropriations Congress made in 2018 and ensures that the Substance Abuse and Mental Health Services Administration will continue all its opioid activities at the same funding level as FY 2019. That includes the $1 billion state opioid response program, which we have focused on access to medication-assisted treatment, behavioral support, and recovery services. The budget proposes to provide a full year of Medicaid benefits for pregnant women diagnosed with an opioid use disorder and take steps to reduce inappropriate prescribing within federal health care programs. Finally, the budget invests in other important public health priorities, including fighting infectious disease at home and abroad. In particular, it proposes $291 million in new funding for the first year of President Trump's plan to use the effective treatment and prevention tools we have today to end the HIV epidemic in America by 2030. This budget will advance American health care and help deliver on the promises we have made to the American people. I look forward to working with this committee on our shared priorities this year, and I look forward to the committee's questions today.
Very good. I thank you for your testimony. Ranking member and I will defer our questions till the end. So with that, I recognize the gentleman from New York, Mr. Higgins, for 5 minutes.
Thank you, Mr. Chairman, and thank you for being here, Mr. Hargan. Firstly, I just wanted to point out that the National Cancer Institute was seeking a $400 million increase in funding over this year for next year. This was intended to bring promising new cancer treatments, particularly in the area of immunotherapy, to market. As you may know, that drug discovery is a process that takes some 10 or 15 years. So when funding is delayed, promising new treatments are delayed, and those promising new treatments are denied for people that are in desperate need of new effective therapies. So the President's budget proposes to cut $900 million from the National Cancer Institute. What is the rationale behind that cut, which is enormous based on anybody's view of it?
When we work within the caps that on the budget, which were set forth by President Obama in this Congress years ago, we face a tough budgetary environment this year. We fully support medical research and the NIH. We know that this is very important to the American people, and particularly the National Cancer Institute is important to ongoing research in oncology and cancer area. Within that, we are also proposing, as I'm sure you've seen, increases for pediatric cancer. So we have attempted.
What is that amount? Is that 50 million?
On pediatric cancer?
Is that initiative $50 million more for pediatric?
Yes, so
Okay.
we're proposing new money for pediatric cancer.
So it's still a cut of $850 million generally to the National Cancer Institute. Does that concern you?
Within the discretionary budget that we have, the NIH is the largest component of our discretionary side of our budget. And we have attempted to be even-handed in how we approached it. We have a lot of different initiatives within the department, and we wanted to make sure that we were as even-handed as we could and as thoughtful as we could when we were confronting difficult.
Well, here's what I would say to you, that government funding has been involved in about 97% of the basic science and research toward the goal of bringing promising new cancer treatments to market. In fact, the last 100 major products from Herceptin for metastatic breast cancer and many of the vaccines for immunotherapy are a direct result of government involvement in the financing of clinical trials that test both efficacy and safety. And a cut of this amount, even when you take into account the increased funding for pediatric cancer, is still $850 million. That will have a devastating impact on what NCI is able to fund to the various cancer institutes throughout the country, including in Buffalo, New York, the nation's first cancer center, Roswell Park. So that's of concern. Secondly, on the issue of Alzheimer's, Alzheimer's is a horrible disease. It inflicts pain not only on the afflicted, but those who love and care for the afflicted. Some 3.5 million new cases will be diagnosed this year. And the primary treatment is a drug called Aricept, and it was developed probably 2 decades ago. And in 60% of cases, it may delay the onset of Alzheimer's by maybe 6 months. This problem is growing, and we don't seem to have a handle on it. I would ask you, what are the administration's initiatives as it relates to developing new treatments for Alzheimer's beyond the Aricept era of those drugs?
We definitely see the impact of Alzheimer's directly on the beneficiaries of our programs. Obviously, a disease like that falls straight into many elements of the Medicare program that we administer. So we take the issue of medical research very seriously across the department to develop new therapies, new modalities to treat it. It has proven a difficult disease to solve, but we're committed to standing behind our researchers that are working on that both at NIH and then in the grantee community that's served with the money that is given generously by Congress to NIH.
Okay. Gentleman's time has expired. I now recognize the gentleman from Missouri, Mr. Smith, for 5 minutes.
Thank you, Mr. Chairman. Thank you, Deputy Secretary Hargan, for being here. Labor HHS has been one of the most difficult funding bills to get through Congress. In fact, fiscal year 2019, Labor HHS being passed by the Republican House, the Republican Senate, and then signed by President Trump was the first time that a Labor HHS bill had passed in over 20 years. And I think it's very noteworthy that the last time that a Labor HHS bill was passed and funded was in 1996, the prior time that the Republicans were in power. And so I find it to be very ironic that my colleagues on the other side may throw arrows at you and may criticize your budget, but yet they have failed to ever, in the last 20 years, to pass their own Labor HHS budget. It's easy to point blame, but it's their turn to govern. And let's see if they govern this Congress in being able to pass a budget and whether they'll be able to appropriate a Labor HHS. I do want to say, Secretary, where did you grow up?
I was actually born in Cape Girardeau, Missouri.
What a wonderful city.
Absolutely.
It's home of Rush Limbaugh as well. So two great people from Southeast Missouri. And it's the great congressional district that I get to represent. So we definitely are very interested of your rural upbringing. How has that affected how you've helped mold this budget?
Well, I didn't just grow up in a rural area in deep southern Illinois after being born in southeast Missouri, but my mother was actually an x-ray technician in a small hospital outside the town of 800 that I grew up in. She was an x-ray tech there for 58 years. So yeah, my late mother was there from 1953 to 2011. So this is the issue of rural health is something that's extremely close to my heart. Having grown up underfoot in a hospital like that, you see the real challenges that are faced by rural hospitals and rural providers close up, and really for my entire life. I was very gratified that Secretary Azar last year instituted a rural health task force that brings together a lot of the elements of the department to focus on rural health particularly. In many cases, agencies deal specifically with their parts of the rural health landscape, and being able to unify that and focus on it when we have a lot of shared issues across the different agencies, I think is going to result in some good effects that we're going to be able to have. And also allowing more flexibilities around the use of telehealth and other sort of technological areas that I think are going to be important to solving rural health issues as we go forward. We're going to need a lot of imagination to deal with the issues that are coming forward, a lot of good thinking about about how we solve the problems with rural health.
We have 9 critical access hospitals in southeast Missouri, 9 qualified health centers that serve almost 130,000 patients in 51 different sites. So when you're looking at a geographic area of 20,000 square miles, access to quality, affordable healthcare in rural America is big. So I appreciate the administration's effort on that. I appreciate your background. Earlier, I stated the fiscal year 2019 appropriations and budget passing for the first time in 20 years. Mr. Hargan, what benefits did you see from the certainty of fully funding HHS?
Yeah. Well, it was tremendous. As you say, the first time in 22 years that we've had a budget passed for the department. So it creates a lot of confidence on our part to be able to plan for the future. We were able to work through a lot of the issues to stand out the new initiatives, say the Ending HIV Epidemic in America initiative that the President announced in the State of the Union address. It allows us to focus on, rather than focus on funding issues, we really focused on new initiatives to help the American people, to allow us to promote new ideas that we're standing out right now.
I do want to state real quickly the proposal and the investment for eliminating HIV in the President's State of the Union is something that I applaud, and also investment in pediatric cancer research. So thank you for being here. Thank you for representing the Show Me State very well. Even though you were just born in Cape Girardeau, we adopt you. So.
Thank you. Thank you, Congressman.
The gentleman's time has expired. Love Fest for Missouri will continue at some point. Chair now recognizes the gentleman from Texas, Mr. Doggett, for 5 minutes.
Thank you very much for being with us, Mr. Hargan. But as to health, Health Secretary Azar, is he ill this morning?
I don't have any knowledge of it.
Well, I know he was offered all week to be here. This is the second week he's been offered an opportunity to come. And it's almost as if the administration has a policy of being fearful of sending its cabinet members to be questioned. Indeed, on the tax bill, we couldn't get anyone at any level of the Trump administration to come and answer questions and be held accountable about the hypocrisy in the bill. So I do find it troubling that he has not come to respond on some of these issues, and all the more so because of what happened yesterday, and that is the decision of the administration down in my home state of Texas to once again throw in the towel with our indicted Attorney General, and not only to go after pre-existing conditions, which you've been doing, but to say that you favor, as our Republican colleagues did 60 or 70 times, the total repeal of the Affordable Care Act. And I don't see anything in your budget that would provide comparable care for the tens of millions of people that will lose out if you and the Texas Attorney General are successful in destroying the Affordable Care Act, which our Republican colleagues tried so often but were unable to do anything about. Let me ask you, since I'm sure we're not going to agree on that, about one issue that I would hope we could agree on that you referred to in your testimony, though I don't see it anywhere in the fine print, and that is this whole question of prescription drug cost and whether we can save taxpayers and seniors anything on that. Candidate Trump made it very clear that he could save hundreds of billions of dollars on prescription drugs, and it seems to me that this budget really abandons that. It goes around the edges. It does not deal with what candidate Trump said on January 11th of 2017, among other times, that we're the largest buyer of drugs in the world, and yet we don't bid properly. And he said we could save hundreds of billions of dollars, and of course, he's right. The estimates are up to $500 billion in annual in 10-year savings that could be had by negotiating drug prices. I don't see anything in this proposal that calls for the negotiation of drug prices, and I would just ask you if the administration is abandoning candidate Trump's promise that we bid, as he talked about it, that we negotiate drug prices in order to protect seniors and to protect taxpayers.
We welcome all of this. We welcome this issue. The president is very dedicated to lowering drug prices for Americans.
So far, he hasn't been too successful, but he has reiterated his desire, and I hope there could be some bipartisan action on this.
We have the first lowering of drug price inflation in 46 years.
Well, he didn't run on a promise that he would keep prices from going up quite as much as they had before. He said he was going to do something to lower them and save us hundreds of billions of dollars. And there's nothing in this budget to do that.
We have seen the actions that have been taken have resulted in companies lowering drug costs for cholesterol medicine, for diabetes medicine.
They've lowered it where they had competition to meet. And I agree with you that competition is a good way to deal with this problem. But unless there's negotiation, as the president himself pointed out when he was a candidate, you don't get where we need to be. And in that regard, I will move from prescriptions directly into one specific prescription and another issue you mentioned, which is the opioid crisis. We know that the price of naloxone from one provider went up about 700%. At the same time, our first responders all over the country were being told to stock it. Chris Christie, who headed the President's Opioid Commission, and more recently, the Office of National Drug Control Policy, Jim Carroll, in testimony to the Oversight Committee here within the last month, have agreed that what we need to do is at least, if we can't get comprehensive negotiation through Medicare, we ought to at least negotiate down the price of naloxone, which can help respond to the fact that we are seeing so many Americans every day, an average of 115 every day die of overdose. Do you agree with Mr. Carroll and with Chris Christie and his commission that we ought to be negotiating on the prices for these overdose drugs?
We believe that the most popular form of naloxone, which is Narcan, the nasal spray, is highly affordable. That there are other forms of naloxone that have higher prices, but we believe that it's widely available to all states and first responders.
Well, I don't agree with you. I thank you for your candor. You don't really think there's a problem on naloxone that needs to be negotiated.
We believe that it's highly affordable.
Thank you very much.
Gentleman's time has expired. Now recognize the gentleman from Utah, Mr. Stewart, for 5 minutes.
Thank you, Mr. Chairman, Deputy Secretary. Thanks for being here. You have a difficult job, but it's important work, and I think you take a very serious approach to that. I want to thank you for that. And the proposal that you have before us that you're here to defend today, I would like to point out before I get to my main point and my question, many parts of it are bipartisan. I was interested to see a New York Times, which is hardly a bastion of conservative thought. Even the New York Times in the last day had an editorial scolding the Democrats for disparaging it and putting aside some of the proposals that you and the president have put forward, saying that many of them make sense, that many of them should have bipartisan support, and they're just practical reforms that will drive down costs. And I could go into that, but again, that's not where I want to spend my time, but I'll conclude by saying this. We will hear again and again and again. We're going to be told that the administration wants to cut $845 billion from Medicare and $1.5 trillion from Obamacare. But again, it's not true. It's just simply not true. About a third of that $845 billion is being shifted out of Medicare, but it's being shifted in other programs. The money's still going to be spent. It's just being spent more efficiently. And again, I appreciate your being here to defend that, and I hope you do so vigorously, because these are defensible positions that you and the administration have taken. Now, if I could get to my point, and that is, like you, I grew up in a small town. In fact, I have you beat on this. You grew up in Mounds, which has 800 people. That was a big city to me. I grew up in a town of 295, had 2 bars. I don't understand how that quite adds up. But in my district, I represent Salt Lake City, but also very rural parts of Utah. Some incredibly beautiful places, Zion National Park and Bryce's and Canyonlands, but these are rural, difficult places to get to here in the country. About a third of my district lives very rural. They drive up to an hour just not to see a specialist, just to see a family doctor. So talk to me a little bit about telehealth. I mean, we think it's incredibly important to providing our rural communities with better health care. We know you're interested in this. Take a few minutes and tell us how we're going to help our rural communities, especially in the West.
Sure. We think that it's got to be one of the keys. We have to get more specialty care. We have to have more access to more sophisticated care to be provided at the rural locations. And between that and the development of healthcare workforce that can get the information, once we're able to use telehealth to provide information into a rural setting, I think we'll be able to see there to be just much more and better provision of healthcare in rural areas. So we have allowed there to be much more flexibility in CMS for the use of telehealth, and we're looking forward to kind of building out on that. And
elaborate on that, if you would, the flexibility and practical application, what that means to a family.
So a practical application would be that if you have somebody who's going to be prescribing to you, can you use telehealth to be able to for a patient in one location to be able to have a screen in front of them, to be able to talk to a doctor. The doctor can then analyze something, make a prescription, then the prescription can be sent by telehealth and then sent barcoded to a pharmacy, and they can dispense it there so that you can actually do prescriptions remotely. You can actually provide, with the sophistication of the cameras and the technology we have now, you can have a lot of things that are done, a lot of visits, virtual visits that are done by doctors that can provide really good and sophisticated care and diagnoses to a patient, which can then be used locally to provide care.
So, Mr. Hargan, I'd be curious, and I don't know the answer to this. One of the benefits, again, my district and others, is to make it more accessible. It can be difficult, especially for someone on fixed income, someone who has some limited capabilities, to travel an hour to see a doctor. That's a great thing. Get that. You just indicated that that was possible. I'm curious whether this is also more efficient. Do we actually save money by some of these processes where the doctor is able to see the patient more quickly and more effectively?
We've been doing research on that. We look forward to sort of further developing that with Congress about what the cost impacts are going to be. But we definitely want to have them move from higher cost settings like hospitals into being able to take care of themselves at home. I personally have sponsored this thing called the Patient Empowering Technology Summit that we're looking to advocate for more telehealth, more wearable technologies and things where patients can have technology for themselves in their own homes, in their own settings, that allow them to have better, more sophisticated care for themselves at home or in local settings like community health centers.
Thank you. I'm out of time, but I appreciate your answers.
Thank you, gentleman's time has expired. I now recognize the gentlelady from Illinois, Ms. Tchaikovsky, for 5 minutes.
Thank you, Mr. Chairman, and thank you, Deputy Secretary. I want to talk to you about Title X, which is the only federal program dedicated to contraceptive health care and family planning services. The program has operated successfully for about half a century and serves 4.1 million low-income individuals, which is why I think its funding actually should be increased. Right now, it's in the budget, it's at $280 million. I think $400 million would be better. But my concern right now is the way that an executive order was issued and a regulation that would dramatically change Title X and the organizations that are possible recipients of Title X funding, providing a tremendous service. I wonder if you could describe in perhaps more specifically what we see, many of us, including providers, as a domestic gag rule, preventing physicians and providers from giving the full story of the full range of healthcare services, including even recommending or referring for abortion services.
The final rule is not a gag rule. It does not prohibit, in fact, it affirmatively permits counseling, non-directive counseling about abortion. So it is, in this way, it's different than the Reagan administration's Title X rule that was upheld in the Supreme Court. What we are trying to do is to make sure that the Title X, the statute we have to obey, says none of the funds appropriated under this title shall be used in programs where abortion is a method of family planning. This rule is intended to safeguard the requirements in the law that require us not to fund abortions or to in the program.
Well, you know that under current law, under the Hyde Amendment, no dollars can be spent for abortion services. But what we're concerned about, and correct me if I'm wrong, that organizations like Planned Parenthood, who provide many preventive services, the single largest organization to receive Title X funding, believes that their programs would have to dramatically change. Not just a matter of providing abortions, but my understanding is that counseling about abortion, leaving it as a potential option, or for with other money, not federal dollars, providing abortion. Are you saying that Planned Parenthood is misinformed and that they will continue to receive funding from the federal government under Title X?
I don't know the details of Planned Parenthood's internal finances or how they arrange their centers. I know as long as they comply with the law, that they will be entitled to apply for the funds under Title X, as long as they comply with the rules and regulations.
Well, how would you define then complying with the law? That's what I want to get at, because many of us feel that the preventing qualified providers who the Planned Parenthood itself sees about 5 million people a year, often for screening for cancer, STDs, for basic health care, that they would be prevented from getting Title X, which is very important.
Well, the final rule is there to help provide high-quality, comprehensive family.
No. I want to know, regarding abortion, how this affects organizations like Planned Parenthood.
I would have to refer you to them for the impacts that they think the rule would have.
No, except that aren't you the person that's speaking on behalf of the administration on a dramatic change? In your view, do you think these changes in Title X will lessen the number of people who get served by Title X?
I don't believe that. We have lots of federally qualified health centers located all over the country, 1,400 health centers.
Other than what? You said we have many other
providers
than Planned Parenthood?
And Planned Parenthood can comply with the rule. They can come and provide these services. And we're not intending to box out any particular provider. We just have to make sure that the law is implemented, and this regulation is intended to implement the intent of that law. So if they intend to apply for this, it's not directed to prevent them from applying for these things, just that they have to comply with the law. So any provider can apply for this as long as they fit within the regulatory framework and the statutory framework.
I think their concerns are warranted, and I yield back.
Gentlelady's time has expired, and I recognize the gentleman from Pennsylvania, Mr. Musser, for 5 minutes.
Thank you, Mr. Chairman, and thank you to Deputy Secretary Hargan very much for being here with us this morning. The President's budget seems to me to be very focused on making health care more affordable, in fact, better for beneficiaries. For instance, the goal is to make prescription drugs far more affordable than over the past. It also provides much more responsibility to the states. And there's no question, I'd say 50 out of 50 states appreciate that. It also addresses, in really an unprecedented manner, and I hear this from drug awareness groups throughout my district, very strong fixes and support to fight the deadly opioid and drug epidemic in our many districts and communities face. So there's a lot of positives. It also has programs such as Medicare Advantage or enhances them by Medicare Advantage has reduced both premiums and deductibles, and I've heard this from many constituents, and the data proves that to be the case. So there's a number of positives. What I'd like to ask is, my district on the opioid and drug epidemic issue, like many communities throughout the country, have some big problems. Can you outline what the department's budget request allocates to address this crisis?
Yeah, I'm happy to. As I had mentioned, I come from a community that has been afflicted by the opioid epidemic for decades. In fact, in my own family, the president has signaled this as the foremost public health crisis of our time, and the budget invests $4.8 billion, an increase over last year in a difficult environment of $123 million. This shows the seriousness with which we have to take this. It is the driver of a 3-year decline in American life expectancy, and the efforts that the administration has been taking has resulted in what we hope to be a flattening and a decline for the first time in years of the opioid overdose deaths that we're seeing. So we're driving both research into non-addictive painkillers, the greater access to medication-assisted treatment, more money for states in opioid response grants that we've been standing out over the last couple of years to really build out the capacity of the states and localities to deal with this, and for families to get access to to the treatment and the recovery services that they need and deserve.
Thank you. You addressed somewhat the issue of rural areas and the support that this budget provides. You did mention something about workforce development. Could you expand upon that?
So we have a number of proposals, one of which say within the Indian Health Service, which addresses a lot of rural areas throughout the United States, where we are trying to focus on the community health aid program. The budget advocates for this, which is providing training to build out a corps of community health aides who can be on the ground in rural areas. And also Indian Health Service is one of our foremost agencies identified by us in fighting the opioid epidemic, which disproportionately affects tribal members. So, and we can get lessons learned from a lot of these things in terms of workforce development.
Great. Can you describe a few of the Medicaid reforms that are in this budget?
Yeah, so the Medicaid reforms, as you had mentioned, are really dedicated to providing flexibilities for states. So we have put forward a block grant program of $1.2 trillion over 10 years that really is intended to refocus the Medicaid program on the populations it was originally intended to serve: pregnant women, children, the disabled, the elderly. So we're really focusing on the most vulnerable populations and giving states flexibility to deal with their particular populations that they uniquely have the knowledge on the ground of how to deal with them. So we've actually stood out more programs, more flexibilities on that side, and $1.2 trillion in a new program to address these issues and provide flexibilities for the states.
Thank you. Just got a couple of seconds here. I will just ask quickly, prescription drugs, are there one or two examples of what you're doing effectively to reduce prescription drug costs?
Yeah, we've seen companies reduce in cholesterol medicines, in insulin for diabetics, and in hepatitis C drugs, where companies actually announced lowering drug costs for patients in those areas, and these are widely used drugs. Millions of people use cholesterol drugs, as well as those dealing with diabetes.
Thank you. Thank you, Mr. Chairman.
Sure. Gentleman's time has expired. Now recognize the gentleman from Nevada, Mr. Horsford, for 5 minutes.
Thank you, Mr. Chairman, and thank you for holding this hearing to allow us to discuss the President's Health and Human Services 2020 budget proposal. I'd like to start off with Medicaid. Today, more than 640,000 Nevadans rely on Medicaid, which provides health coverage to children, pregnant women, parents, seniors, and individuals with disabilities. President Trump promised during his 2016 campaign that he would not cut Medicaid funding. In fact, on May 7, 2015, then-candidate Trump tweeted, and I quote, "I was the first and only potential GOP candidate to state there will be no cuts to Social Security, Medicare, and Medicaid." Deputy Secretary, can you tell me and my constituents back in Nevada why the President is now breaking his promise and proposing to cut Medicaid by $1.5 trillion over the next 10 years?
The budget does not propose to cut. It cuts and adds in $1.2 trillion, as I mentioned, in new grants that allow flexibilities for states to respond. So
those new programs are being paid for through cuts to the existing Medicaid program, correct?
So it shifts. The budget shifts the money from being paid as it currently is to more flexibilities on a different line. So it might appear to say it cuts Medicaid by a certain amount, but actually the money is mostly shifted into a more flexible budget line. So we're standing out the market-based healthcare grants to the states, which is going to allow them to focus the program more flexibly.
Yeah, as a former state legislator, having worked on budget issues, we understand what those block grants to the states would actually mean for states like Nevada that have population growth. It's not going to actually allow us to keep up with our healthcare needs. Let me turn to the HIV eradication. President Trump, in his State of the Union speech, said it's his goal to end the U.S. HIV epidemic. And while that's a very commendable goal, I question the approach. Some of my colleagues have talked about the $1.2 billion cuts to global health programs, but we can't ignore the cuts the Trump administration is making to domestic health care programs that help address HIV. You see, Medicaid is the single largest source of coverage for all Americans with HIV, and this plan looks to gut the program. This will be detrimental in Nevada, which has the 7th highest population of individuals with HIV in the nation. Evidence shows that reducing federal funds through a per capita or block grant would limit Nevada's ability to respond to public health crises such as the HIV epidemic or the opioid epidemic. Without Medicaid coverage, 8,900 people living with HIV in Nevada will likely go without any care. So, Deputy Secretary, how does the administration plan to make up for the loss of care for HIV patients?
We have proposed to end the HIV epidemic in America by 2030. This budget proposes $291 million targeted to the areas that account for 50% of new diagnoses. We are dedicated to ending this scourge for all Americans, and we follow the advice of our public health specialists, our researchers. That
you're not answering my question.
We think between
reclaiming my time, can you answer the question? How does your plan specifically seek to end the eradication of HIV when you're making these dramatic cuts?
We are going to be standing out through the community health clinics, more access to PrEP, which will allow us to suppress the virus on the front end prophylactically, and then also maintain funding for the Ryan White Care Act, which allows us to, which is where we get the ART for people who are infected. So between PrEP and ART, and through community health clinics and through the state and local based elements of the Ryan White Care Act, we believe that we'll be able to, through those, and continue.
I'll look forward to getting more information since it's not very clear. I want to just mention on the issue of telehealth, I know the budget does factor in $44 million of additional money to telehealth grants. I just visited a number of rural healthcare centers in my district last week with FCC Commissioner Starks. However, based on the need that I heard from those providers, $44 million, while an increase, still seems rather inadequate based on the information that I received from those healthcare providers. So I would ask the administration to really look at that based on the fact that it is an area where we may share some agreement. Thank you.
Thank you, Congressman.
Gentleman's time has expired, and now recognize the gentleman from South Carolina, Mr. Timmons, for 5 minutes.
Thank you, Mr. Chairman. Thank you, Deputy Secretary, for taking the time to come before our committee today. We're hearing a lot from my colleagues across the aisle about the changes in spending. The spending priorities have been proposed are different than last year, and these cuts that we keep hearing about, I understand some of their concerns, but I want to talk to you about a different kind of cut. We have $22 trillion in debt right now. We passed a $1 trillion deficit budget. What happens when our credit limit runs out? It's not a question of if, it is a question of when. So whether it's 5, 10, 20 years from now, or next year, I want you to give me the scenario of a 20% across-the-board cut to your budget.
Well, as you've seen, we're trying to preserve the viability of these programs. In fact, in the budget, we're extending the life of the Medicare Trust Fund by 8 years, just simply by lowering the rate of growth in the program from 7.8% to 6.9%. And by taking some of the elements out of the Medicare Trust Fund that may not really belong there, like graduate medical education or uncompensated care money, by moving those out into the general fund, we're extending the life of the Medicare Trust Fund by years, which helps us keep our promises to America's seniors. Just by enacting some common sense reforms to these programs, we're going to extend the life and the promises that we've made.
Let's get more specific, though. So next year, you get 25% less dollars. Just specifically, what would you have to do?
You know, I would say that if we had if we have hypothetical scenarios, we work through a lot of these different elements. In 25% scenario would be a huge cut. This year, we've proposed a 12% cut in our discretionary lines. within the budget. It would require a lot of thoughtful work on our budget people's behalves to make sure that we could balance out the necessary areas of focus, like, for example, this year, opioids, pediatric cancer, where we're trying to focus on these areas. But it would require a lot of difficult decisions.
Would Americans see reduced quality of health care?
With a 25% cut, it depends on where we would hopefully be able to work to make sure that there were no lowering in overall care for Americans. We would do our best.
You would do your best, but 25% less money, it would be catastrophic.
It would be a blow to have to endure larger and larger cuts as time went on.
So the Budget Committee of the United States Congress should take very serious steps to make sure that that doesn't happen.
You know, I think that we've laid out some common sense reforms in this budget that would enable us to take action in time to prevent, to make moderate changes now that would prevent worse decisions taking place later on down the line.
Thank you. Thank you, Mr. Chairman.
Thank the gentleman. I now recognize the gentleman from Virginia, Mr. Scott, for 5 minutes.
Thank you. Mr. Horgan, if an agency, does your budget anticipate funding agencies that discriminate based on religion?
We enforce all the civil rights laws and all of the constitutional safeguards that are given to us in trust.
Okay, so if an agency said that they're going to discriminate in hiring based on religion, and then turn around and say if it's an adoption agency, only consider certain religions for adoption, would that disqualify them from federal funding, or would you support that discrimination in hiring and in providing the service?
We can balance the needs of grantees and their religious expression that's one of the constitutional guardrails.
Is that a yes or no?
That we are given to enforce.
Would that agency be disqualified by virtue of the fact that they intend to discriminate in hiring with the federal money, only hiring, say, Christians, other religions need not apply, and then only considering for adoption services, Christian families, other religions need not apply? Would they be disqualified from federal funding?
So I assume you're dealing with the Miracle Hill.
I'm not, I'm just asking a general question.
We have to protect both religious expression.
Is that a yes, you would fund such an agency?
We have to protect all the constitutional rights.
Is that a yes, you would fund such an agency? Let me ask it another way. Is it yes, you have funded such an agency?
South Carolina approached us with a request for an exception to allow them to place more children with foster care.
Is that a yes?
In loving homes.
Wait a minute. An agency intends to discriminate based on religion and hiring, and then based on religion, they're going to disqualify families from participating in adoption services.
No family is disqualified for participating in adoption services. Anytime that an organization like Miracle Hill, they are referred back to the state, and the state or another agency. So anyone who wants to participate in that as a foster parent can apply to the state, can apply to another agency.
But not that agency. That agency is going to discriminate. Is that right?
The agency is allowed to
discriminate,
to express.
And they can use federal funds doing that.
The agency is allowed to express its religious.
I'm just trying to get a straight answer. I mean, this is a very straightforward question.
No one is prevented from participating in that foster care program.
But the agency can disqualify them. They're not going to consider any non-Christian adoptive parents. Is that right? And you're going to give them federal money?
The state agency.
Excuse me. You gave them federal money?
The state agency will not turn away anyone who
wants
to apply to be a foster.
Did you fund? Are they spending federal money and discriminating? Yes or no?
We give money to the state.
Oh, yeah, okay.
We give money to the state, and the state
we've
gives
gotten
it
the
to an
point.
agency.
You have funded an agency that has the express intention, I don't know if they're doing it or not, but discriminating and hiring with federal money and disqualifying that agency, parents who are not the right religion from participating, and they're using federal money.
I couldn't, as a Catholic, participate as a foster family with that organization.
And you gave them federal money?
I couldn't participate.
You gave them federal money. Let me get to talk about block grants. Is it true that you community services block grant that reduces poverty, did they get zeroed out?
I believe that we have not allocated money for that.
And social
program.
services block grant, supportive services for families, did they get zeroed out?
Like other programs where we have sort of low results
Is that
for
a
the
yes?
program, we zero them out.
And you're going to a block grant with, in terms, after the Affordable Care Act is, your plan anticipates ending the Affordable Care Act and replacing it with a block grant? And the block grant will increase annually with inflation, is that right?
Yeah, we have the whole provision set out.
Okay, and the inflation, is that regular inflation or medical inflation?
I would have to get back to you. I believe it's regular inflation.
And so what's the difference between regular inflation and medical inflation?
There are lots of different calculations for different kinds.
Medical
of
inflation is a lot higher than regular inflation, so every year you'd be falling by, the purchasing power of that block grant would be eroding every year based on the difference in inflation, is that right?
If the inflation rate that year were higher than regular inflation.
Oh, come on. Inflation rate for medical inflation has been higher than regular inflation. When was the last time it was not higher?
I don't know. We'd have to get back to you.
Oh, yeah. Okay.
Gentleman's time has expired. I now recognize the gentleman from Oklahoma, Mr. Hearn, for 5 minutes.
Thank you, Chairman. Ranking Member Womack. Deputy Secretary Hargan, I want to thank you for your work you do in promoting and enhancing the health and well-being of the American people. I appreciate your work and this administration's commitment to lowering the cost of prescription drugs, protecting the unborn, combating the opioid crisis, and many other ideals. This administration's equal commitment to health and fiscal responsibility is commendable. First, I'd like to express my support for the Department of Health and Human Services' final rule separating abortion from family planning. Until now, the Title X program accounted for nearly 60% of Planned Parenthood expenditures from all agencies reported between 2013 and 2015. During this time frame, Planned Parenthood received $170 million of taxpayer money through the Title X program, an average of $56 million annually. While previous regulations violated longstanding conscience laws and required all Title X recipients to refer for abortion, the final rule ensures that none of the funds appropriated for Title X may be used in programs where abortion is a method of family planning. The elimination of the egregious abortion referral mandate appropriately protects the conscious rights of health care providers. Abortion is not family planning, and I'm grateful for this administration's acknowledgement of the fact. So, really briefly, I'd like to know what else this department is doing to ensure that they are allowing our great medical care providers to protect their religious freedoms and consciences while on the job.
Thank you, Congressman. We have set out in our Office for Civil Rights a division for conscience and religious expression to be able to protect, to be able to investigate potential violations of our conscience rule. That is to protect people's conscience rights and their religious rights when they're providing medical care. There are a number of statutes that have been put in place over years, some stretching back decades into the 70s, that protect Americans who are in the healthcare sector, that protect both their conscience and their religious expression rights. Under this administration, we now have staff that are going to be dedicated to making sure that those rights are not violated.
Thank you, Mr. Secretary. I'd also like to ask you about the medical device tax. This fundamentally flawed public policy was put into place in an effort to pay for the Unaffordable Health Care Act. This punitive tax punishes businesses in a specific industry for innovation. It is the epitome of the war on business, and it is already having a major negative impact on the competitiveness of vital, world-leading American industry. According to data from the U.S. Department of Commerce, the U.S. medical technology industry saw its job ranks fall by nearly 29,000 while the medical device tax was in effect. In 2017 study by the American Action Forum assessed that this rate of job losses would likely return if the tax goes back into effect. Those workers earn an average of $58,000 annually, well above the national average for manufacturing. First, do you support the repeal of the medical device tax?
Yes, I and we do.
And what is your department doing, working with Congress, urging them to, so let me just rephrase it this way. What is your department urging Congress to do to keep the healthcare industry competitive?
Yes. We are supporting innovation on all fronts, not just through medical research that we're doing on NIH, but we're also going to try to enact a series of regulatory reforms. For example, I am chairing something called the Regulatory Sprint, which is going to hopefully help deburden a lot of areas around coordinated care. That's going to allow there to be more innovation in this area. We think that innovation is really, in many ways, a solution to some of the healthcare problems that we have, and it's a way in which we can kind of solve some of the problems that whether cost and also help American industry. If we can support innovation in this country, we're really going to support the position of the entire United States. It's the largest sector of the American economy, and whatever we can do to help enhance innovation in this country is going to help not just the Americans as patients, but also American industry as well in the healthcare sector.
Thank you, Mr. Secretary. Mr. Chairman, I yield back.
Gentleman's time has expired. Yeah, I don't know what's going on with the mics here. Still working out the kinks. Now recognize the gentlelady from Texas, Ms. Jackson Lee, for 5 minutes.
Mr. Chairman and Ranking Member, thank you so very much. And to the Deputy Secretary, thank you for your service to the nation. I'm going to ask very quick questions, and I'd appreciate, as best you can, answers that would move as quickly as possible because my time is limited. Let me start out by saying in 2012, there were 45.6 million people that were uninsured. As the Affordable Care Act began to do its work, 2018, 28.3 million, 8.8% are uninsured. I think every life, every child is valuable and should have access to health care. Do you believe that, yes or no?
Yes.
Thank you very much. Let me, with that in mind, let me begin methodical questions. It is my understanding that the President's budget includes $1.5 trillion in Medicaid cuts over 10 years. Part of the work of Medicaid is cutting HIV transmissions. Part of its work is dealing with prescriptions. Part D plans must cover all HIV drugs, but the administration now is limiting the coverage of drugs when we're seeing a surge of HIV. Is that giving a death knell to people who are suffering from HIV? What mindset would cause you to engage in cuts in people who are fighting for their life?
As you know, the President is dedicated to ending the HIV epidemic in America
by his works, not his words, by his deeds.
We're putting $291 million new dollars into fighting HIV. Both are expanding access to PrEP and as well as ART. So the main forms by which people fight this terrible scourge, we are enabling people to have access.
But I'd be interested in your answer about the fact that HIV transmissions and drugs that are going to be excluded are going to be lost. That opportunity is going to be lost. You admit that?
We hope that access to effective HIV therapies is not lost, but it's going to be enhanced.
But we're hoping that. Let me move on to indicate that you are cutting $130 billion from Medicaid over 10 years. What is your estimate of the people who lose Medicaid coverage?
Well, we believe that what we're doing in this budget is, first of all, as I indicated earlier, while there are cuts in the budget, there's also $1.2 trillion in grants that are going to go to states to enable them to
in block grants
to focus on the most vulnerable.
And that is a challenge. Do you know how many people in your new work formula will lose Medicaid because of the mandatory work requirement, and these people are unable to work? Do you know how many people will lose it because of that?
We believe that we're going to look for the effects of the community engagement requirements that we have in states right now. We are hopeful with the strong economy that we have right now and that has been enabled by President Trump's reforms.
Forgive me for reclaiming my time or restoring my time. I know you're believing in hope. I want you to see the picture of devastation. Let me also say, coming from Texas, we were the poster child for the uninsured. Now the administration is going in to implode, blow up, and destroy the Affordable Care Act with its position on the Texas versus Azar. Were you involved in that decision-making?
Litigation strategy is with the Department.
Do you agree with throwing out the Affordable Care Act that's been a lifeline to many people?
President Trump wants to make sure that people with pre-existing conditions and all the
That will be impossible if he blows up the Affordable Care Act. What is his substitute right now? Does he have a bill that's going through the House and the Senate that he's going to pass and sign?
We have spelled out in the budget
You have no legislation that will deal with that. So let me deal with the unaccompanied children. How many unaccompanied children does HHS anticipate needing services for in 2020? How much are you asking for?
We are asking for an expansion of our ability to transfer to 20% and then a $2 billion contingent fund that will enable us to deal with influxes and surges into this.
And do you have an accounting? I've asked almost every administration representative that comes before my committees, plural. What is the number that you have right now?
It's between 11 and 12,000.
And that 11 and 12,000 has been a steadfast number of holding and incarcerating children. Aren't you part of the process of getting them connected to their family members?
We want to make sure that process takes place as quickly as possible.
Then can I ask you to ask the president to cease and desist of incarcerating these children and these kinds of... I wrote the legislation, so let me just say I understand. We in judiciary tried to find alternative places for children as opposed to the detention conditions, but now it's become an industry, and you're asking for another $2 billion.
We want to make sure that the children's welfare and safety is at the center of everything we do at HHS.
I will be back in touch with you. Let me quickly ask, Head Start, you're lowering the Head Start funding. With the Head Start funding, you're going to be able to serve 1/3 less eligible children, and we know that it's only reaching less than 1/3 eligible children, and you're proposing to reduce it. How are you going to help the children that need to be in Head Start with reducing the budget?
We are actually focusing our efforts on making sure we preserve programs that have demonstrable effects like Head Start and the child care programs where we're putting forward actual new proposals on child care. I think $1 billion more money into a child care fund.
And Mr. Hargan, you're losing slots, and the parents are begging. I would beg that to be revisited, as we will revisit it, in terms of all these questions that I asked. These are desperate situations, desperate times, and they need the help of the federal government as it relates to health care, HIV/AIDS, and of course, Head Start, and many others. So I beg of you to be a voice of reason for this administration. I yield back.
Gentlelady, time has expired. Now recognize the gentleman from Tennessee, Mr. Burchett, for 5 minutes.
Thank you, Mr. Chairman. And thank you for being here, Ranking Member. Thank you, sir. I won't beleaguer questions that have already been asked, being number 436 out of 435. I'm going to wing it on a couple of things that I was curious about. On these deductions or supposed cuts to Medicare, Medicaid, but you say that, in fact, you're going to basically, correct me if I'm wrong, you're going to take the bureaucracy out of it and send it to the states and allow them to share in the responsibility of providing this care, and maybe the aspect of local control is best. Is that primarily what I understand you saying, sir?
Yes, it is.
Okay, that's I want to get that straight. Two other issues I was concerned about: the pediatric cancer investment. I salute you for that, and along with the HIV investment. I guess my biggest concern is I've seen up here both parties do it, so it's not like it's any big secret, but it seems that in funding bills, we reward and we punish. And you see funding for research for things, and it possibly spread out among members who are maybe more cordial with others than some are, and than some that aren't. And I'm wondering, and I guess my biggest concern is for things like pediatric cancer. You know, we've got St. Jude's in Memphis, which is on the other end of the state, but they clearly do the Lord's work. I'm wondering if you all are looking at areas where there could be duplication, because in that funding, it seems a lot of times it has very little to do, at least in my layman's view, of the ones that are actually delivering the goods, but it's going to the more prestigious areas that maybe that more prominent members represent those districts. And I'm concerned of duplication. I just like to get to the bottom of it. I get to the cures, take care of these sick folks, and quit with all the politics. I don't care if they do it in Dan Crenshaw's district or Tim Burchett's district, but if they're solving the problem, that's where the money needs to go. And I hope you all are addressing that duplication that I see a lot in research, because it seems to me that, we just keep reinventing the wheel on some of these things, and if we could consolidate, maybe have some collaboration within these institutions, that we could solve some of these problems. If you would just comment on that.
I think that's probably the central case that we're trying to deal with here. Pediatric cancer has been very fragmented and siloed in a number of different places that we think has sort of dragged at the ability to make as much progress in this area as we would like. So us being able to kind of gather information on the data, get it together into a single place, and determine where we're seeing better results within pediatric cancer is kind of central to the problem that we have articulated to ourselves. So the President's initiative on pediatric cancer, a lot of it is going to be addressed precisely with what you're talking about, which is the fragmentation and siloing of pediatric cancer research in the past.
Use the term silo. I understand what that means, but could you explain that to Mr. Crenshaw? Because I'm not sure that he understands exactly what that means.
Yeah, there's often a development straight up in a particular area. They don't talk to each other, right?
I honestly, I don't know what siloed means, so if you can just explain it to me. That was me saying that, trying to look a little smoother, but you didn't catch on to that. But go ahead.
I guess coming from a farm, I did use a rural term. So siloing, we often find that people don't talk to each other within this area. They don't share data collaboratively within this area. And it's just the development of these long-standing ways of doing business that we hope to be able to overcome.
Okay.
To bring the information together, stop the fragmentation, stop the non-sharing of data, and prepare a single data resource that is available more broadly that will allow us to kind of make some steps forward in this area.
Thank you, brother. I yield the rest of my time, Mr. Chairman. Thank you for your indulgence.
Well, I thank you, sir. The chair now recognizes the gentleman from California, Mr. Peters, for 5 minutes.
Thank you, Mr. Chairman, and thank you, Deputy Secretary Hargan, for coming to join us today. One of the challenges in healthcare is keeping premiums down, and I think you'd agree that one of the ways we do that is to make sure we get young people into the pool. Would you agree with that?
There are lots of ways to address those issues with the pool.
I just said, was it one of the ways is to get younger?
Possible one of the ways is to bring lower cost people into the pool.
Right, and we did have a mechanism in the Affordable Care Act, which was enacted before I got here, so I have no pride of authorship. The individual mandate was intended to get people to come in. And now, after you're 26 and you come off your parents' insurance, assuming you have it from them, there's no real incentive to get you to get in the pool. And I noticed that one of the things that the proposed budget do would be to cut advertising by 90% and in-person consumer assistance by more than 80%, close to $150 million. Don't you think it would be useful to help get the word out that insurance is available in terms of, as one mechanism at least, to get young people who are healthy into the pool and keep insurance premiums down?
We have seen towards as the ACA enrollment has developed, we've seen less and less use of navigators, for example, that they weren't really connecting people at some point. We had one result where we had spent $200,000 and there was a single person enrolled by a navigator in one area. That's an area where it seems like there was some waste going on.
I certainly think we should root out the waste. I'll just tell you that California's experience has been at variance with that. California, according to Covered California, and Mr. Chairman, if there's without objection, I'd ask that the Covered California summary of marketing matters be added to the record.
Without objection.
They'll spend over about $111 million on marketing outreach. We're just one state, although we're 40 million people. And they believe that the amount that they've spent has kept premiums down by 6 to 8%, and that if the federal government would go ahead with its 72% reduction in marketing, there will likely be one fewer Americans getting insurance, less healthy risk pool, and premiums will be 2.5% higher now, higher than they were in 2019. They also say that the premium savings or the expenditures on advertising would yield more than a 500% return on investment for the federal government. We know that getting folks in, if there's no mechanism to do this through requirement like the the individual mandate, all we've got is advertising, and it's worked well in California. I just don't understand the logic of bringing us to this point.
When we previously had reduced some of the advertising and navigator money, we saw really very little effect on enrollment, and we have seen that private plans had themselves advertised for their own product, and that we were seeing a lot of brokers and agents that had appeared privately to guide people into the plans. So we didn't really see a lack of enrollment, that there had been kind of a period where those navigators and the advertisement that had been done had been useful in the early stages when people were less familiar with the ACA, but now we've seen that really being transitioned into the plans themselves and brokers and agents guiding people.
Again, that's at variance with California, which has had the most successful uptake rates in the country, and I guess I'd suggest we learn a lesson. I wanted also just to comment generally on, someone mentioned the New York Times editorial on Medicaid cuts, that we should work together. And I want you to know that I'm someone who wasn't here when the Affordable Care Act was passed. I believe it's a tremendous undertaking to remake the entire healthcare system in the United States. It's going to need tweaks, but it's hard for us to talk to on one hand to you about these changes, when on the other hand, the President's Justice Department is out there trying to sabotage the whole thing. It puts us in a very defensive position. And I know this is not something that was up to you. I appreciate your work on the Affordable Care Act, on making it right and making it work for people. But if the administration's trying to cut out the whole thing, it makes it very, very difficult for us to feel like we're in a cooperative mood or feel that we can trust it. And I think I ask that you take that back to the administration. Finally, I just point out that your budget would cut funding by $4.5 billion on NIH, National Science Foundation, by 13%. This is a devastating blow to biomedical research, particularly devastating in San Diego, where the life sciences industry is a major driver of economic growth, home to more than 1,000 biotech companies, 80 independent research and university-affiliated research institutions. According to NIH, investments in research focused on a particular area stimulate increased private investment in the same area. A $1 increase in basic public research stimulates $8.38 of industry investment after 8 years. A $1 increase in public clinical research stimulates an additional $2.35 of industry R&D investments after 3 years. Have you estimated the devastating impact that these cuts would have on our economy?
Well, we are fully behind the medical research mission of NIH, and we know that the things that are done by the staff at NIH and by our grantee network is very important for the health of the American people.
Well, I've suggested that this is extremely counterproductive, and I think it should be opposed. Mr. Chairman, I yield back.
Thanks. Gentleman's time has expired. Now recognize the gentleman from Texas, Mr. Crenshaw, for 5 minutes.
Thank you, Mr. Chairman. Thank you, Deputy Secretary, for being here on this very important subject as we have a hearing about what is almost a third of our budget. Under HHS, tell us again, how much of that budget do you manage? Mandatory and discretionary.
Yeah, it's $1.3 trillion budget, about a little over a quarter of the federal budget.
It's an enormous amount, and we don't have an infinite amount of resources. So anytime we budget, this is always about choices. And I want us to recognize the fact that as politicians, we often get elected by promising action, by promising more. We take advantage of this human preference for more things, especially if somebody else might pay for those things and we don't have to. It's a cultural trend that's going on in this country, and it affects everything. It's an unsustainable cultural trend, this idea that someone else should take action so that you don't have to. And there's also this idea that the states are completely incapable of managing their own systems of government. This unsustainable cultural trend, it also leads to completely unsustainable policies. And Medicare is one of those. Medicare is completely unsustainable. And that greatly affects a generation like mine. I just turned 35, and I have really little hope that I will see Medicare in my lifetime. But there's a good chance that you'll have to raise my taxes considerably to pay for this unsustainable program. And it frustrates me that on the Republican side, we often have to be the adults in the room and say, hold on, we can't promise all of these things. So on Medicare specifically, I want to talk about some of those things that are driving those costs. What what are some of the main elements driving the unsustainability of Medicare, and what are you doing to fix that?
Well, some of the things were really things that were put into Medicare trust fund that really didn't belong there. Things like uncompensated care, things like graduate medical education. Simply moving those out into the general fund means that Medicare trust fund is the reckoning is delayed by a number of years. Also, just lowering the amount of spend from 7.8% growth to 6.9% has a tremendous effect overall. Then we also address some of the issues where some of the payment rules have kind of gotten by making things more neutral between sites of care.
Okay, and how does this affect the consumer of Medicare, our senior citizens relying on? Will they see these changes?
They won't see these changes. These changes are not to beneficiaries. They're not going to increase out-of-pocket costs to seniors. They're not going to affect the beneficiaries' access to any one of these things.
That's a very important point. Thank you. I also had an interesting note from a group of nurses in my district. They said, we don't need Medicare for all, we need primary care for all. It's an interesting look at things. Are you familiar with direct primary care?
Yes.
What is the administration doing to foster more direct primary care, this market-based solution to gain more access for people for primary care?
So one of the things that we're doing is by allowing more money to be put into health savings accounts and allowing people to manage their care more through either health reimbursement accounts, health savings accounts. So if they're able to do this, they're able to access direct primary care. We're able to provide more flexibilities in the budget at the state level, but also at the patient level, that's going to allow people to be able to have access to direct primary care.
Excellent. It's amazing what can be accomplished in our markets if we let people take back their own money and use it for things like direct primary care. I also want to ask you about the pay for delay regarding generics and biosimilars and what the administration is doing on that front.
Yeah, so we are proposing a whole suite of reforms in this area. So in the case of pay for delay, we intend to actually reduce payment for drugs where a company has engaged in gaming of the system, like pay for delay, where they pay another company to keep a competing drug off the market.
Okay, the last question I want to ask you about is graduate medical education. You've made some reforms to that. In Texas, we are unfairly discriminated against compared to other states when it comes to GME. We have less spots according to our size and on our needs. Does this help states like Texas? Does this equalize it across the board? It's unclear what these reforms will do.
So by consolidating some of the fragmented programs that we have right now, we're going to be able to put them into a single overall graduate medical education program, and we hope that's going to allow for a more rational approach to GME. It could include things like allowing places that are under-resourced to be resourced.
Thank you. Thank you, Mr. Chairman.
Absolutely. Gentleman's time has expired. Now recognize the gentlelady from Washington, Ms. Jayapal, for 5 minutes.
Thank you, Mr. Chairman, and thank you so much for being here. Just to my colleague across the aisle, when you talk about adults in the room, perhaps I wish you were here last year when we were talking about the GOP tax cut, and we clearly said at the time that this was a three-step dance, that the Republicans were going to cut taxes for the rich, that would then explode the deficit. In fact, it has estimates $1.9 trillion, and then that would lead to demanding big cuts to the things that Americans really care about, like Medicaid and Medicare. And I think, Mr. Chairman, that we are right at that place here. And I hope that I'll have a chance to talk about my Medicare for All bill that really takes on a broken health insurance marketplace. I believe we will on Budget Committee, and I look forward to telling my Republican colleagues about exactly what that looks like. Mr. Hargan, I wanted to start with questions about HIV and Medicaid. There are over 955,000 individuals living with diagnosed HIV, and it continues to be a significant health concern in the United States. But thanks to the gains of our scientific and public health community that we've seen in improved screening and treatments, over 90% of individuals with HIV survive for more than 3 years after the diagnosis. In his State of the Union address, President Trump announced a new initiative to end HIV transmissions by the end of the decade. And the president's budget provides $291 million to support that initiative. However, very important for the American people to understand, it includes $1.5 trillion in Medicaid cuts over the next 10 years. And Medicaid is the largest source of insurance coverage for people living with HIV. And that's because as of 2017, 32 states expanded Medicaid coverage to include individuals with HIV who were previously excluded. And so now more than 40% of people with HIV who are receiving treatment are covered by Medicaid. How is the goal of ending HIV transmissions achievable when the administration is simultaneously proposing to cut roughly a quarter of the Medicaid budget?
So while we had moved a reduction in one line, we actually plussed up $1.2 trillion in flexible grant money for states in Medicaid. So the shift is really from one type of program to another to allow there to be more flexibility for the states in Medicaid and allow them to concentrate on the traditional vulnerable Medicaid populations, the elderly, the pregnant women, children, the disabled. So we are really moving the money.
But you're talking about converting Medicaid into a block grant or a per capita cap and then requiring states to implement so-called work requirements, all of which would strip Medicaid as we know it. That's essentially what you're talking about. Let me move on to public health in the United States. Comprised of federal agencies, state health agencies, tribal and territorial departments, and more than 2,500 local health departments. These are systems that protect us not only from emerging health threats, but also serve our everyday needs like immunization, food safety, and delivery of health services. And that's why the CDC, our nation's health protection agency, dedicates 85% of its domestic funding to state and local public health departments. And yet, the president's budget proposes cutting the CDC's budget, that's the Center for Disease Control, by nearly 20%. What is your justification for cutting this major source of funding for local and state public health agencies and an agency that's central to the prevention and transmission of disease in the United States?
Well, we had just proposed, in terms of CDC funding, there's really only a net decrease of 1% from FY 2019. So our net decrease in funding for it is really just about 1% for CDC. In a difficult environment, we really did preserve public health funding for CDC among our agencies.
Maybe my numbers are wrong, so it's not a cut of nearly 20%?
No, we had moved from $12.1 billion in FY 2019 to $12.0 in 2019.
Well, that's good. If that's true, that's great, and I apologize for getting that wrong, and I hope that we actually see an increase in CDC funding, which would be even better. I want to just, actually I don't have time, I wanted to just put on the radar the public charge rule that we are deeply concerned about and that would strip care for a number of people across the country who might be seeking care that is legitimately provided through state programs, and introduced for the record a letter signed by 111 members of Congress around the public charge rule. Mr. Chairman, I ask unanimous consent to introduce that letter.
Without objection.
Thank you. Thank you, Mr. Hargan. I'll follow up with you on the CDC thing because I don't usually get those things wrong, but if I did, I apologize. Thank you.
Thank you. Gentlelady's time has expired. I now recognize the gentleman from Georgia, Mr. Woodall, for 5 minutes.
Thank you, Mr. Chairman. I'd like to endorse what my friend Ms. Jayapal said. She rarely gets things wrong, so I hope you'll share it with us too, Pramila, when you find out what that is. CDC sits in my backyard, and so I tend to associate myself with the numbers Mr. Hargan has in front of him, and we're also proud of that mission, but it wasn't always that way. CDC was woefully underfunded in the 80s and the 90s, and only when we realized what we'd missed out on did we finally redouble those efforts, so I appreciate your focus on that. Mr. Hargan, I want to talk about some things that I think went right and some things that could go even better. I know you've already gotten an earful about things folks don't like, and they don't think we're moving in the right direction on. I want to move in the right direction. You've done some work on pressure ulcers as it results to hospital discharges. That's something that's near and dear to me personally, but it's also near and dear to me as a budget hawk because we throw away a lot of money on preventable hospital-acquired illnesses. When the Appropriations Committee last cycle asked HHS to go back and look at pressure ulcers to see if we were doing all that we could do. You came back with a new model that based on a 10-factor scale, used pressure ulcers as one of those to say we can do better than the 58% increase in pressure ulcer discharges and do better down the road. We've got a lot of great groups. One is in my district, Monlicka, that has an amazing technology that we can do more, not do more with less, but do more and prevent more bad outcomes, and thus we end up spending less. The entire Pressure Ulcer Association is working along those lines, and you all have well, I would say moved with the efficiency one would expect from a government agency, that you can take that as you see fit. But there's some good work that's happening there. There's more good work that can be done, but I want to thank you for that. Also want to put on your radar screen, I know you've been busy preparing for this hearing, the House, the General Assembly in Georgia yesterday passed a bill that will give our governor permission to ask for two waivers. One's an Affordable Care Act waiver, another is a Medicaid waiver. I listened to Mr. Peters as he challenged your numbers, talking about all the good work that California does. I have no doubt that California is doing good work, and I have no doubt that the failures that you observed in the case of a $200,000 program, only signing up one individual, I have no doubt about the accuracy of that either. We can do better in Georgia. No offense to the federal laws and statutes, regulations that are on the books. We just have more experience in rural Georgia than you do. We have more experience in metropolitan Atlanta than you do. And so when those waiver proposals come forward, I just want to encourage you to look favorably upon those. There are limited resources. Can you tell me a little bit about the resources dedicated to approving those waivers and whether or not we'll be able to, I know so many are coming across your desk, will we be able to proceed on those expeditiously?
I would say that, we very much look forward to, if Governor Kemp brings the proposal forward to us, we very much look forward to engaging with him. We know that the states and localities know a lot more about their unique needs than we do here in Washington. So we know that they're going to be in the best position to know the unique needs of their populations there. So, I would say we applaud states for bringing creative proposals forward to us. So we're going to look forward to engaging with him if he brings it forward after the passage of the bill.
I don't see my timer. Oh, there I am up on the wall. Let me ask that, re-ask that specifically. When we get to the appropriation cycle, folks will take money out of administrative accounts and put them into things that feel better, like NIH funding, like CDC funding, and so on. Are we at risk underfunding the administrative account at HHS of not seeing those applications acted on as quickly as we'd all like to see them acted on?
I think that the administrator at CMS is going to focus what she needs to focus on having a swift analysis and resolution of whatever we have, whatever is brought forward by Governor Kemp or anyone else creatively in the 1115 space.
I don't know if you've been down to the CDC recently. It's always a good excuse to go to Atlanta. Security is one of the things that troubles me. We spend a lot of money on science, but we don't spend as much money on security. You're in a difficult space. Health is the focus, but bad security leads to bad health outcomes from time to time. Is that an issue that rises to your C-suite level?
Particularly cybersecurity is an issue that we take very seriously. We deal a lot with data, with science, with new ideas, with new science and intellectual property, and so cybersecurity is a big issue, both for Americans to make sure that their health data is kept secure, for researchers. So we've actually stood up a health sector coordination, cybersecurity coordination center at HHS that is going to help facilitate maintaining in security over a lot of the information that Americans entrust to their doctors, to the healthcare system, and to HHS.
Mr. Chairman, as I look at the pictures on the wall, I see that only Mr. Panetta was brave enough to leave Congress and go and serve in the administration afterwards. So thank you, Mr. Hargan, for what you're doing. Clearly, it's not something that we choose to do. I yield back.
Right. Gentleman's time has expired. I'll recognize the gentleman from New York, Mr. Jeffries, for 5 minutes.
Thank you, Mr. Chairman, for your leadership, and thank you, Deputy Secretary Hargan, for your presence here today. Medicaid provides health coverage to 7.2 million low-income seniors who are also enrolled in Medicare. Is that correct?
Medicare serves tens of millions of people.
The answer would be Medicaid provides health coverage to 7.2 million low-income seniors, correct?
Yes. I'll take your number as being accurate.
Roughly 60% of all nursing home residents receive Medicaid coverage. Is that correct?
I'll take again your number as being accurate.
Do you think that nursing home care is an important part of our healthcare fabric here in the United States of America?
Yeah, all different kinds of post-acute care settings are important. Skilled nursing facilities, long-term care facilities, home health. We seek to make sure that whatever setting Americans want and choose what's best for their care is enabled.
So nursing home care is important, correct?
Nursing home care can be important for the right senior.
Close to half of all long-term care services for the elderly are paid for by Medicaid, true?
It's an important component for individual nursing home payment.
Medicaid also covers premiums, deductibles, and cost sharing for Medicare beneficiaries. Is that correct?
In certain settings, yes.
Medicaid provides coverage to 27 million children under the age of 18 in the United States of America, true?
Again, I'll take your numbers to be accurate.
More than 700,000 children in Medicaid expansion states gained coverage between 2013 and 2015. Is that correct?
I'll take your numbers as accurate.
And research shows that children with Medicaid coverage have better health care outcomes as adults. Is that true?
Could you repeat the question?
Research shows that children with Medicaid coverage have better health outcomes as adults than those without Medicaid coverage, correct?
I'm not familiar with that research.
Okay, but the totality of the import of what Medicaid provides, I think, is well established, and you've agreed in several different areas that Medicaid is covering a substantial number of Americans, from children all the way to low-income seniors and those who are receiving care in nursing homes. So for the life of me, I'm struggling to try to figure out why this administration proposes essentially to slash $1.5 trillion in Medicaid and create a smoke and mirrors block grant program that will devastate the ability of these recipients who rely on Medicaid to receive care. Now, the president, during the campaign, promised that he would not touch Medicaid. Is that correct?
The president is fully committed to supporting the Medicaid program.
Why is the president breaking his promise, not just with respect to Medicaid, but also Social Security and Medicare, by submitting a budget that would cut approximately $2 trillion?
The budget proposes a shift into a $1.2 trillion new program to allow states to flexibly deal with the most vulnerable populations that Medicaid was intended to address: the elderly, the disabled, pregnant women, children. So we're fully committed to that, and that's a $1.2 trillion new program that we are advocating for in this budget.
And you propose creating this $1.2 trillion new program because you want to address alleged waste, fraud, and abuse in the current Medicaid program. Is that right?
We want to make sure that states have the flexibility in the new program to address the unique needs of their populations and focus the program on the traditionally vulnerable, fragile populations that Medicaid was intended to address from its very beginning.
Okay, so at minimum, even if we assume that this new $1.2 trillion block grant program is going to actually reach the people who are currently being served by Medicaid, which there's reason to doubt, you're cutting at least $300 billion from Medicaid. Can you give me a single example of the type of waste, fraud, and abuse that you are trying to address that would justify billions of dollars in cuts? Not millions, not tens of millions, not thousands, billions of dollars in cuts. Can you give me some understanding of the waste, fraud, and abuse that you're addressing?
Actually, over 10 years, Medicaid spending goes up under this budget plan. So we are not addressing actually a lowering in the budget of Medicaid spending, but actually increasing.
Can you give me a single example of the waste, fraud, and abuse that justifies cutting billions of dollars from children, low-income seniors and those receiving nursing home care?
Our Inspector General and our Centers for Program Integrity are constantly working to identify areas where there are waste, fraud, and abuse that take place throughout our programs. We have entire...
Reclaiming my time, I assume that's a no. I yield back. Thank you.
Gentleman's time has expired. Now recognize the gentleman from Texas, Mr. Roy, for 5 minutes.
Thank you, Mr. Chairman. Appreciate you coming here to testify today and taking the time to join us here. Just as a threshold matter, the national debt today is what? Do you know? 22 trillion, over 22 trillion? Does that sound about right?
That's my understanding.
I was recently PolitiFacted that I made a comment in a hearing that we're racking up $100 million of debt per hour. And I actually got a mostly true out of PolitiFact, which basically means it's the book of Luke in the eyes of PolitiFact. If I get a mostly true, $100 million of debt per hour, right? So I just, as a backdrop to the questions that we're gonna ask here, with respect to some of the Medicaid questions that were just asked, it was alleged that it's smoke and mirrors when we talk about block granting Medicaid. Are you familiar with some of the studies and some of the state organizations and think tanks, for example, the Texas Public Policy Foundation, which would suggest that they might be able to save upwards of $4 to $5 billion in Texas in administering Medicaid if they were able to get the money in form of a block grant? Is that where some of the kinds of savings you're talking about?
I'm not familiar with their particular study, but we've certainly seen lots of examples from our program integrity initiatives and otherwise where we see examples overall of waste in programs.
Well, I appreciate that. And also with respect to Medicaid, we talked about a whole lot of the, quote, gains in coverage for Medicaid. Are you also familiar with some of the studies and think tanks, for example, the Illinois Policy Institute, which pointed out that there are literally thousands of people that are on waiting lists and Medicaid rolls because of the number of people that were jammed onto Medicaid rolls after Obamacare and the expansion of Medicaid, so that people who were for whom Medicaid was originally designed are on the outside looking in because of so much burden being placed on the Medicaid system. Is that an accurate depiction, at least in some areas of the country?
That is certainly something that we've heard.
Is it also true that we've had upwards of 6 million or more people who lost private coverage since Obamacare has been put in place in the private market?
I'm not sure the exact number, but we certainly had people who lost their plans in the wake of the passage of the Affordable Care Act.
Okay, I appreciate that. And then one last question on Medicaid that I'm just curious, is with respect to Medicaid expansion, has anybody in the administration, as a secretary or anybody in the administration, actively encouraged states that have not expanded to embrace a partial expansion or expansion now? For example, Texas, which is not expanded.
We only entertain things coming from the states, as opposed to, say, encourage or discourage. Normally, we are responding in that program to initiatives coming from the states. So, for example, in the Georgia case that was just cited, if the Georgia legislature passes that bill and the governor brings it to us, we're going to entertain that within the statutory restrictions that we have.
Okay, thank you for that. One last question on budgeting. Do you all ever engage in what some people might refer to as zero-based budgeting or building it up from the ground up, or do you basically budget off of last year's numbers and so forth when you work with OMB and others to get the budgeting process done?
We work with OMB on any number of different scenarios for the budget, but generally, we abide by the rules that they give us in order to base off our budget line.
But you're unaware of that budget. This isn't what you might refer to as a zero-based budget.
This is abiding by the CAPS agreement for President Obama and the Congress passed years ago.
A couple of questions on the $2 billion line in the budget for unaccompanied alien children. Do you know how many alien minor children that is meant to try to deal with over the next 3 years? And am I correct, it's $2 billion allotted for the next 3 years?
Yeah, it's a $2 billion contingent fund for the next 3 years if the program needs it and exceeds the transfer authority. And in this case, we've asked for 20% transfer authority to the UAC program.
Is this mandatory or discretionary spending?
I believe this is a mandatory. The $2 billion is on the mandatory side, I believe.
Okay, so I guess my question, do you have any estimate on how many UACs we're preparing for in coming up with that $2 billion number?
We have to look, really within HHS, we deal with the children when they're brought to us. We can look at ins and outs. There are great differences year to year. That's why we had a contingent fund as opposed to asking for more increased money every year, just because there are great fluctuations with the number of unaccompanied alien children coming over the border year to year, month to month, day to day.
Well, and to that point, right, in fiscal year 2018, CBP apprehended 50,000 unaccompanied alien minor children at the southwest border. Just between October and February, we saw 26,937, which means we're looking at a higher number. We've seen a massive expansion over the last several months in February and March. If we see the numbers that are coming across that we're having to deal with. My point being, is it fair to say that the burdens of what's happening at the border, with our inability to secure the border, is putting a strain on HHS's budget because we're having to deal with this problem and failing to secure our border?
Fundamentally, this is traced back to a broken immigration system and the fact that we have to deal with a tremendous number of children that we are going to care for, we're going to advocate and make sure that their child welfare and safety is the utmost, and that we move them to an appropriate sponsor as quickly as we can out of these shelters. But it does mean that there's huge numbers of children being sent to us to take care of, and that does place a strain on our budget.
Thank you for that. Thanks for being here.
Gentleman's time has expired, and now I'll recognize the gentleman from California, Mr. Khanna, for 5 minutes.
Thank you, Mr. Chairman. Thank you for your leadership. Thank you, Secretary Hargan, for being here. Secretary Hargan, you worked for President Bush, is that correct?
I did.
And you were there during his tenure and when he was doubling NIH funding, is that correct?
Yes, I was.
You probably remember that President Bush ran saying that we need to double the NIH budget in 5 years. Do you remember that?
Yeah, we were, I believe, continuing over a doubling that was taking place at NIH.
Yes, no, it's kind of you to give President Clinton credit. He started it, and then President Bush continued it. Are you aware that when President Bush took over, the NIH budget was $17 billion, and when he left, the NIH budget was $28.6 billion?
I'll defer to your numbers on the past numbers for NIH.
I was recently with Secretary Condoleezza Rice, and she said, one of the biggest things we can be doing for this country is doubling funding for the NIH and National Science Foundation. Would you agree with her comments?
I believe that, as I said, medical research is core to part of the mission of HHS to enhance the health and well-being of the American people. We stand fully behind NIH and its medical research mission, both for it and for the grantees that it enables to do that important work. Within the CAPS agreement and the budget that we have, we have to operate within the budgetary environment we've been given by the CAPS agreement that was entered into.
In your opinion, though, when you looked at President Bush's approach and the approach Condoleezza Rice is recommending, I mean, they also had to operate within hard budgets. They found the money to double NIH. Do you think their approach was better for our competitiveness or the current president's approach? Well, I mean, they're two very different philosophies.
I have great respect for Ms. Rice. But we also have to operate within the legal environment that we have, the budgetary rules that are put in place. We can't violate those. And we have to prepare our budgets realistically within the bounds that are set for us by law. So in making those decisions, we have to abide by the agreements and the laws that were given by the Congress.
You know that in the context of the federal budget, $4.5 billion, do you think that's a significant percentage? If you just had to guess, I mean, it's probably less than 0.1% or 0.5% of our federal budget.
And we're attempting also within the NIH budget to preserve focus on a lot of the important focuses that we have within opioids, within pediatric cancer, within the HIV epidemic. To focus within those and to save those areas within NIH, apart from the overall budgetary environment that we're in, a tough budgetary environment dealing with the CAPS agreement.
Well, would it be fair to say that President Bush and Condoleezza Rice put a higher priority on the National Institute of Health than this current president?
Well, President Bush was not operating in an environment where there were discretionary caps. And so there were sort of fewer restrictions on this, but we have to operate in an atmosphere of discretionary caps.
Would you say that, I mean, we were meeting President Bush, and he asked you, do you think President Trump has as much of a priority on the NIH? What would you say to him?
I would hope that President Bush would understand, as we've just talked about, which is that in an environment with no discretionary caps versus an environment with real discretionary caps, you have to operate in those areas.
Do you think
there were hard decisions made in the budget under President Bush? I was in leadership at HHS at that time, and we had hard decisions to make. And we have hard decisions to make here, and hopefully we've made them as thoughtfully as we can for your consideration when you're working through the budget.
So you stand by the $4.5 billion NIH funding cut and the $897 million cut for National Cancer Institute. Given your experience, your service in the Bush administration, your views with Condoleezza Rice, and her basic view that we ought to be doubling in, she understands the budget constraints. I'm just trying to understand, and I mean this with respect, are you defending this because that's your job? You work for the president, he gets to set the direction? Or do you really think that his vision is better than Bill Clinton's and George Bush's and Barack Obama's and every single president before him in modern time who wanted to increase funding for the NIH?
Well, I would say we have something around a $99 billion discretionary budget at HHS. NIH has been $38 billion of that. It's the largest single item of discretionary spending within our department. And we have many programs within that we have to, within the CAPS agreement, within the cuts to discretionary funding and the caps that we have to abide by, we have to try to be as thoughtful as we can in that environment to make sure we comply with the law and the caps that were sent to us.
Thank you.
Gentleman's time has expired. I now recognize the gentleman from New York, Mr. Morelli, for 5 minutes.
Yes, thank you, Mr. Chairman, for hosting the hearing, and thanks to the Deputy Secretary for joining us I was going to say this morning, just about this morning and afternoon. Let me just editorialize for just a second. I'm new to the Congress, and I note that in the budget, there are a number of changes which have been discussed by my colleagues regarding Medicare payment policies. For a number of these changes, however, the budget does not indicate how much they would cost or save the government, and I'm just struck by the footnotes that say estimates were not available at the time of budget publication. And I just note that I find it unusual and strange that you could recommend policies without knowing exactly how they'd affect federal spending on Medicare, both to the government and to beneficiaries. But if I can, I just want to jump around and in the limited time, related to investments. I recognize, as many members have talked about, the impending challenges of Medicare and mandatory spending as the population ages, as costs will grow, and there's a need to clearly address this. I would do it from the point of view of investments and looking at key investments and whether spending on those investments do, for instance, in the area of healthcare, what the triple aim that everyone talks about, better outcomes, better experience for patients, and bending the cost curve. One of the investments that we make typically is in graduate medical education. I represent the University of Rochester, which is an academic medical research facility. The budget restructures federal support for graduate medical education, cuts the funding by a total of $48 billion over a 10-year period by capping funding. It grows at less than the rate of inflation. The population is aging. There's a growing need for doctors in areas such as primary care and gerontology. How does this proposal improve the health care and the health needs of the workforce to meet the needs of that growing senior population?
The reforms that we're advocating for in the budget are intended to better focus the federal spending on healthcare professionals because we're consolidating GME programs that are currently fragmented into a single program. By consolidating these disparate streams of funding, we believe that we're going to be able to address shortage areas, rural health, making sure that we have better training of professionals to build a stronger healthcare workforce that's more targeted to the needs that we have now. That we have them when we have these different funding streams consolidated. If these reforms are undertaken, we'll be able to reorient these programs.
But it does. I'm sorry to interrupt, but I appreciate that. But there is a significant cut in dollars that accompany. It's not only the consolidation, which I might argue maybe there's some valid reasons to do that, and we'll give you more authority. But the $48 billion cut is a real one, even as you combine the programs into a single program.
Yeah, again, we're operating within a tough budget environment. We do understand the needs to work to make sure that the next generation of the healthcare workforce is in place. We're hoping that by doing these targeted reforms, we'll be able to kind of sort of skate to where the puck's going to be in terms of graduate medical education.
Thank you. Let me jump now briefly in the few moments I have left. The budget calls for no increase in funding for Head Start. Another investment I think is very important, particularly as we're trying to get to children in poverty, getting to read at grade level. You fund the program at the same level as that of 2019. Your own internal documents show funding will support 871,000 slots, down from 890 funded last year. Head Start currently reaches less than 1/3 of eligible children. Why would we reduce the slots in the 2020 budget?
Holding Head Start level in a tough funding environment like this is showing what a priority we place on this program. We've actually attempted within a very tough budgetary environment where we've had to put cuts into some programs, trying to maintain level
Would this be a
funding.
program, I'm sorry to interrupt, but would this be a program you would increase if you weren't in a tough budgetary cycle?
I think we have to abide by the restrictions on the discretionary funding that we've been given by the existing law. But we've held it level, and that's attempting to make sure that we show the focus that we have on programs that we think work.
I do want to, and you don't need to respond to this, but just acknowledge that the budget also eliminates $250 million in preschool development grants, which help build state and local capacity. Many of my colleagues often talk about local and state governments being closer to the people, but it reduces their capacity to provide preschool to low and moderate income households, and another troubling, in my view, cut to a significant investment to people who would be far more productive as citizens if we could give them that support. And I yield back my time, Mr. Chair.
Gentleman yields back. I now recognize the gentleman from New Jersey, Mr. Sears, for 5 minutes.
Thank you, Mr. Chairman. Mr. Hargan, thank you very much for being here. You know, New Jersey, we have about 1.7 million people that take advantage of Medicaid, about 1.4, although to Medicaid, the other of us are involved in the CHIP program. I see that the budget proposes to implement a work requirement for Medicaid in all recipients in all 50 states. Are you aware that when they implemented the work requirement program in Arkansas, how many people lost their coverage?
We have seen, I think, the latest numbers of people show a sort of average churn in the Medicaid program. We have not yet seen, it's very early days in Arkansas's implementation of that community engagement requirement. So we've seen so far, the numbers show an average number of people passing in and out of the program.
Well, the numbers that I got is about 16,000 people lost their coverage in Arkansas when they implemented the work program.
Do you have a question?
Yeah, well, I'm following up on the question. I understand also that you're also cutting $130 billion. You anticipate $130 billion in savings on the Medicaid program?
We have a number of different ways, places that we're showing savings in the Medicaid program.
Well, how much of that do you think is from kicking people off the program by requiring them to work?
I don't know that it's going to depend on how different programs are implemented in different states. This is ultimately a Medicaid issue, which means that it's a state-directed program. So each state is going to come in with a different way of dealing with the community engagement, requirement that they want to put into their own state. Some of them, they're going to have different structures. They're going to have different ways in which the populations deal with the community engagement requirement. Ultimately, it's a state set of requirements that they come to us.
But you are anticipating that if you ask a work requirement, there'll be people losing their coverage.
That could happen. but it's also, and certainly Arkansas has structured some of these things so that people have the requirement in there. If they don't obey the requirement, it is an issue for them maintaining Medicaid coverage. There are also other requirements that states put into place. If people get work of a certain level, they leave the Medicaid program. If people move out of state, if they don't return their paperwork, there are other ways in which people lose Medicaid coverage.
Yeah, but to me, this looks like this is a way of cutting the Medicaid programs by requiring people to work, knowing full well that you're going to lose coverage on people. So therefore, you slash it.
Primarily, the community engagement requirement is intended to help people.
How can that help people when they get off the program?
We know that there are studies dealing with social isolation, dealing with the behavioral and mental health effects of people who do not engage with their community. By states that come to us that have a thoughtfully structured way in which to encourage people to have community engagement, whether it's work or other forms of community engagement, that's an area where we believe that people are going to be well affected both in their health and it can have also physical effects on the state as well as having good effects on people for engaging in work, to have money in their pocket, to have more engagement with their community. If that's the way in which the program is structured, we think it can have a number of good effects, not just dealing with keeping the sustainability of the state Medicaid program moving forward from a physical point of view. It has other effects as well.
So what are the bad effects?
What are the
bad effects? You have all these good effects that you're telling me. What are the bad effects that you anticipate?
Well, we're hoping that any state that comes in is going to avoid bad effects by structuring a community engagement requirement so that, say in the case of Arkansas, that people who are primary caregivers for children, people who are medically frail, people who are full-time students, people who a doctor or medical professional says can't work or shouldn't work, are exempted from the program. So hopefully the restrictions on the community engagement requirement themselves will help obviate bad effects of the program, but also enable people who can engage in the community to encourage them to do so.
Thank you, Mr. Chairman. My time is up.
Gentleman's time has expired. I now recognize the gentleman from Massachusetts, Mr. Moulton, for 5 minutes.
Mr. Hart, thank you very much for joining us. Does the President believe that individuals should be able to deduct health care insurance premiums from their taxes?
I believe that we have stood forward a lot of different proposals in the budget regarding health care. It depends on the type of things that we've certainly advocated for greater expansion of health savings accounts.
Well, if you don't know what your president has proposed, he said during the 2016 presidential campaign that his plan to reform healthcare included allowing individuals to deduct all of their insurance premiums from the income tax that they owe. Historically, which Americans are most likely to benefit from these tax deductions? Wealthy Americans, poor Americans, middle class?
I would, for tax issues, I would have to refer you to possibly the Department of Treasury for...
Well, the answer is that wealthy people can take advantage of deductions. The President's budget justification states all individuals receiving subsidized coverage should contribute a portion of their health insurance premiums. So, the President believes that individuals making $12,490 or families of 4 with a household income of $25,750 should pay more towards health care. Does the President's budget propose wealthier Americans pay more for the cost of health insurance?
I believe that we are trying to reorient...
Actually, just quite a simple question, Mr. Hargan. Does the President's budget propose that wealthier Americans pay more of their costs for health insurance?
We are proposing greater expansions of health insurance options to all Americans. We are actually proposing areas like where we expand more options that cost less for Americans.
That's great. So I've given you a chance to dodge the question. Now maybe you could just answer it. Is it yes or no?
So short-term plans cost 50 to 80% less for Americans by expanding options, all health insurance.
So the President is not asking wealthy Americans to pay more, but he is asking poor Americans to pay more for health insurance. You know, my Republican colleagues often state during these hearings that there is a philosophical difference between Republicans and Democrats on spending. And I agree. Apparently, Democrats think that the poor should pay less, and Republicans think that the poor should pay more.
We are in support of the ACA exchanges. We've been implementing them all along, and they provide a tremendous.
So the president supports the affordable. Wait, the president supports.
The administration has carried out the ACA exchanges, and
so would you be willing to say that the president supports the Affordable Care Act?
We obey the law within the administration. We have put.
Does the president support the Affordable Care Act? You said he supports the exchanges.
We have put forward alternatives to the ACA. But
just does he support it or not?
But as long as it's the law of the land, we are going to continue to provide premium support.
Well, that's heartening to hear. We certainly know that we have a president who loves to follow the law of the land. Mr. Hargan, who famously said that the most terrifying words in the English language are, "I'm from the government and I'm here to help"?
Not sure who the actual originator of that quote is.
May have been a speechwriter, but of course it's attributed to President Ronald Reagan. So even with his quest to limit the federal government, he signed into law the Low-Income Home Energy Assistance Program during his first year in the White House, which specifically protects millions of low-income households each year from extreme heat and cold when high energy bills exceed their ability to pay. So how much does President Trump propose for this program in fiscal year 2020?
Zero.
Okay. And his justification states that it's because there are 15 states that offer similar protections. So what about the people so unfortunate to live in the other 35 states?
Many states make it so that utilities cannot cut off service to people during periods of severe weather. Also, 2010, the GAO found that that program was not high performing, had lots of problems with waste and fraud. We believe that this is not a program that is a very high performing program.
So it sounds like if it's not high performing, the problem isn't with the poor people who can't afford to heat their homes, but the administrators of that program. And as the administration, you're in charge of the administrators of that program. So why not reform the program rather than forcing low-income people to freeze?
The program.
Sorry, my time has expired.
I thank the gentleman. I now recognize the gentlelady from Minnesota, Ms. Omar, for 5 minutes.
I will just pick up, I think, where my colleague left off. I'm from the state of Minnesota, and we are very much accustomed to having extreme cold weathers. And so I understand the need for us to worry about what happens when families aren't able to heat their homes. So the program that my colleague was talking about helps 6.3 million households. In Minnesota alone, there are 120,000 families that utilize this particular program. And so my question to you is, what do you propose happens to these families who now have health and safety problems because of the extreme cold weather?
Well, I'm from Chicago, so I understand the issue about cold winters. When we have a program that does not have strong performance outcomes, and LIHEAP is one of those that has had this going all the way back to when I was at HHS under President Bush, and when the GAO tells us that it's at risk for fraud, for improper payments, and we look at it.
But sir, there's a difference between what my colleague is suggesting about us reforming and figuring out the best ways to utilize the dollars that we have, and saying $0 should go to assist people who live in conditions where it gets as low as 12, 30 negative.
So all 50 states have protections for people who cannot pay their bills in periods of severe weather. So
where would the resources come from if that protection exists? Yes, you mean by legislation?
Every state protects people from their electricity, their heat being cut off during periods of severe weather. So in the LIHEAP program is really duplicating protections that are out there. $3.7 billion to duplicate protections that people have already who are disadvantaged. Now, 15 states have alternative programs that really duplicate by providing payments and other things, but all 50 states protect people against having their...
So let me get this clear. You have 15 states out of the 50 states that have programs where there are resources to help assist people. Other states just have a protection that might say, you might not be able to cut this off or other things. But we're deciding that there is no resources from the federal government that is going to help any of these people, correct?
Well, they're protected. So they're not going to lose their heat. They're not going to lose their cooling.
But protection and providing resources for them to do that are totally two different things. You know that, and you're trying to say otherwise. So we'll just move on. I wanted to, for the remainder of my time, talk about the child care budget within the budget that you proposed. The budget includes a one-time temporary funding of $1 billion to help address the cost of child care. It is unclear whether this approach will ultimately achieve the intended goal. Why are you only providing it on a one-time basis?
Well, this money, which is one-time mandatory funding, which we put in place due to the CAPS proposal, it is intended to augment what we think of as being the most effective parts of our budget in social services, which is supporting child care and allowing states to build out capacity to provide new ways to provide child care.
And how will the funds be distributed? How is it going to be up to the states to determine what regulations they will use to meet the definitions of unnecessary?
Yes, so this is going to be provided as a grant to state to help businesses and localities to help them provide new ways of doing childcare and hopefully to reach underserved areas, rural communities, and communities that are underserved with childcare.
All right. Thank you. I yield back.
Gentlelady's time has expired. I now yield 10 minutes to the ranking member for his questions.
I thank the chairman, and again, Mr. Hargan, thank you for being here today. I will say at the outset, I appreciate you being patient with my friend from Rocky Top, Mr. Burchett, who was trying to get a question answered and blaming it on Crenshaw's lack of knowledge of something when it was actually his own. But what can you say about a guy that walks around in a Carhartt jacket when it's pretty moderate outside and with a big hole in the right sleeve? But that's Tim. He's a great guy and fellow mayor, so I appreciate him, and he does a very good job on this committee. You were asked a few questions in the hearing by 2 or 3 different members on the other side of the aisle from me. Questions about HIV initiative, yes or no questions, those type, treatment of foster care within the budget request. There were a handful of other questions that you were attempting to close on with your answers, and but because of their quest for yes or no answers, not given an opportunity to explain. I'll give you a chance here for a moment or two if you'd like to finish maybe some of those thought processes on those subjects and any others that you'd care to expound on regarding this particular part of the president's budget.
Well, thank you for that. I mean, I think that some of the questions about the effects that Medicaid might have on people with HIV, as I had explained, we're actually replacing the cuts or reductions in one line with an increase on the other side and flexibilities. So we don't believe that a state would choose to disadvantage a particular population or places being served, just simply because they're given more flexibilities in funding. So, we're hopeful that to the extent that people think or fearful that the states would cut Medicaid funding to HIV, we don't have any idea that that's what would happen. And in the meantime, we're increasing funding for HIV, $291 million. It's clearly one of the primary focuses of this department to address that issue, to end that scourge for Americans. So we want to make sure that focus is really, really clear on that. With regard to the issue of Miracle Hill, there is no one who is going to be turned down as a foster parent who is suitable, otherwise suitable, as a foster parent by the state of South Carolina. If an organization like Miracle Hill has a parent like me, for example, as a Catholic, who is not going to qualify for that program, they're going to refer me, and they're supposed to refer me to another agency or to the state for me to apply and get inside the foster care program. We have to. The American people have given HHS a budget of $1.3 trillion, a tremendous amount of authority in some of the most intimate and personal parts of their lives. And in return, we have to obey the constitutional safeguards and the legal safeguards that the American people expect us to obey. In some of those are the Bill of Rights, the constitutional safeguards of people's religious expression. That has to be a cornerstone of everything that we're doing. And so it is important to us that we can do both of these things. We can make sure that we both fund important social services and healthcare activities and also obey the Constitution. We have to be able to do both at the same time.
It was said earlier, and I can't remember which one of my colleagues made the comment, but about the prospect of healthy kids, kids that have access to health care at an early age, typically would be better performing physically from a health perspective later on in life. I can sign on to that. I think that's a rational, reasonable approach. But I would also ask whether or not that same healthy child early on in life is going to be well served if in fact that later on in life the costs associated with what we're doing today are piled on to that generation of children in the form of higher taxes in order just to meet the daily needs. So $22 trillion in debt, I think you would agree is a pretty substantial amount of money that we owe currently. Yes. And that $1 trillion deficit that's going to be added to that $22 trillion in debt is also a very significant amount of money. Yes. So in your business, when you're preparing a budget, you're having to take just like people at home, people watching this hearing today, do this at home. They take their income and they take their expenses, they compare the two, and then they have to make what I call tough choices. So you have to make tough choices. What are some of those tough choices?
So, some of the tough choices that we have to make are situations where we are seeing that we're going to have to reduce the rate of growth in programs. Those are tough choices. We have to make choices between making sure that different sites of care are equally provided. Those are going to impose potential costs on providers, but not beneficiaries. We have to maintain the focus that the seniors, the beneficiaries of our programs, are taken care of and that they don't have an increase in out-of-pocket cost. But at the same time, we have to have reforms in these programs, or they will not, as you rightly point out. Will they be sustainable for the long run? We have to make sure that they are, and that the child today, that we're going to endeavor to have the best health care possible for them, that these programs are around for them. And that's why we tried to adopt a thoughtful approach in this budget that extends the life of the Medicare Trust Fund by 8 years, and that does so with making thoughtful choices within a tough budget environment.
My colleague, Mr. Sears, brought up the state of Arkansas, my home state, and changes it's made to its Medicaid program regarding, the work requirement. Are you familiar with a work requirement? What is that work requirement?
So this is a community engagement requirement that we've allowed Arkansas to put into place. There are a number of elements of it, but Arkansas, while requiring people to engage in community engagement or work, also has a lot of safeguards on that program that we have built into place to make sure that really this is targeted towards people who can engage in work, who can engage in community engagement, so that people who are caring for a minor child, 17 or younger, are exempted from that program, that we have people, anyone who's caring for an incapacitated person, people who have substance use disorder. Those are all categories that are exempted from the community engagement required by Arkansas.
How many hours are they required to work?
I believe it's
it's about 20 hours a week.
20 hours a week. I think it's 20 hours.
20?
Yeah, I think it's 20 hours a week.
Think that's reasonable?
Well, it's. I think that it's probably not a work week. So a lot of people work a 40-hour work week. Arkansas is requiring 20 hours.
In my area, in the 3rd District of Arkansas, the unemployment rate is significantly below 4%. In my home county, it's probably 2.5%, which I would assert is very close to full employment. Lots of jobs, lots of opportunities. In the 16 or so thousand people that have lost their Medicaid coverage, isn't it true that we have, because of the youth of the program, so to speak, the fact that it's not a mature program yet, we don't have a longitudinal study on its effects, but isn't it possible that many of those 16,000 people have entered the workforce?
Yes.
Is it possible that many of those 16,000 now have acquired some form of health insurance through their employer?
Yes. I mean, we definitely know that this economy is the strongest than it's been in years. We're seeing unemployment rates that are lowest they've been in 50 years, lowest African-American unemployment, Hispanic unemployment, female unemployment. We see those very high numbers. We also know that besides employment issues, we also see that there are other reasons why they move out of the state. There are lots of reasons why people leave a Medicaid program, and we look forward to engaging with Arkansas on that and figuring out exactly why people might drop out of enrollment, but it's nothing out of the ordinary. The percentages we're seeing in terms of what we call churn within Medicaid, people coming in and out of the program, we have not yet seen a significant effect statistically in that from Arkansas.
Mr. Hargan, you got a tough job in a constrained resource environment where we find ourselves consistently with trillion-dollar deficits and a $22 trillion debt. The country is going to have to look at its spending habits and the promises it has made and going to have to make some of those tough decisions. And I applaud the fact that over in HHS, they are looking at programs to reform for long-term sustainability because so many people rely on the programs, but at the same time with an eye toward the future in terms of our fiscal solvency. With that, Mr. Chairman, I yield back my time.
I thank the gentleman. I now yield myself 10 minutes for my questions. Once again, Deputy Secretary, thank you for being here. Thank you for your responses. You have, on a number of occasions throughout your testimony today, talked about the constraints of the budgetary caps under the Budget Control Act of 2011. Perfectly understandable. You also said, if I remember correctly, that you appreciated the spending levels in 2019 that you're working under now that was much more adequate for the programs that you're trying to manage. Can I infer from those comments that you would be supportive of raising the budgetary caps for 2020 and 2021?
We do not formulate budget policy within HHS. We only work with Office of Management and Budget within the CAPS environment to present to you what we hope is a thoughtful budget that's compliant with the CAPS agreement. So I would refer any questions on overall budgetary policy to OMB.
But you did say that you appreciated the spending levels in 2019. It made things easier for the department.
Well, I think we appreciated, for example, the opioids, the great support for the opioids initiative of the president, and that Congress had great support for from a point of view of resources and authorities within the opioids initiative and the Support Act, all of which we very much appreciate.
Well, if you were to have spending levels for 2020 and 2021 that resemble 2019 levels, would you still make the cuts that you're proposing to make in this budget?
Well, we would have to, whatever proposal was made by the Congress, we would have to, work with OMB and throughout and the rest of the administration to come up with hopefully a wise budget for you that, depending on the priorities that you all establish, that we have in the administration.
Okay, thanks. Last night, DOJ announced that the administration believes the entire Affordable Care Act should be invalidated, sending a message to the federal court in Texas where a case is under appeal. Were you or others at HHS consulted on this DOJ decision?
DOJ sets the litigation strategy for the federal government. We don't have independent litigating authority.
Were you consulted, or as to, for instance, what kind of impact that ultimately might have if the courts totally invalidated the ACA?
Well, as things stand now, the judge has not issued a stay or enjoined the Affordable Care Act, so it will have no impact as it stands on our administration of the Affordable Care Act. But this administration, the Trump administration, stands ready to work with the Congress on policy solutions like those in our budget that empower consumers and states to regain control over their health care and increase affordability and continue to protect individuals with pre-existing conditions.
Right. I'm going to spend most of the rest of my time on Medicaid, but I have one question on Medicare, well, two questions on Medicare. Has anyone in the HHS ever considered increasing the Medicare withholding tax?
The which, could you repeat that?
Considered increasing the withholding tax that funds the Medicare Trust Fund?
I don't think that the budget sets forth an increase in the withholding tax.
But has anybody ever discussed that, to your knowledge, in this administration? I mean, we talk about adjustments to the program, but we always talk about it on the spending side. We never talk about it on the revenue side. I was just wondering whether, since it's been for a very long time since that tax has been changed.
I don't believe that we have proposed that.
All right, thank you.
Any changes to the withholding tax.
Thanks. We talked from time to time during the hearing about different things that affect the Medicare costs, prescription drugs being one, of course. Aren't there things in the statute that or rules that need to be changed because they drive up costs unnecessarily? I'm referring, for instance, to the Medicare 3-day rule. You have to spend 3 days in a hospital before you can get post-acute care paid for by Medicare. Every physician I've talked to thinks that's an absurd rule.
I think we would love to work with you. You'd mentioned drug pricing. We would love to work with the Congress on a lot of issues that have been stood out in the blueprint, and that we would very much welcome working with you and providing technical assistance to you all on drug pricing reform that brings the costs of prescription drugs down in this country.
You talked a number of times, again now getting to Medicaid, about how you want to increase flexibility for the states. In recent years, a number of states with Republican administrations that had initially decided not to expand Medicaid, thinking about Arizona, I'm thinking about Utah, there's several others, referendums and otherwise, and they've made the decision, after watching what had happened over the first few years of the ACA, that it was to the benefit of their citizens to expand Medicaid. How does your initiative comply with that degree of local control that those states exercised?
Well, states that, when we provide the flexibilities, we would hope that the states would welcome the amount of flexibilities that we would plan to provide them under this initiative, and that they would also welcome the fact that that Medicaid is oriented towards those vulnerable populations that it's intended to cover. That we have other programs that are outside of Medicaid and that we're proposing that would cover different kinds of populations, and we would allow more flexibilities across the board, more choice and more competition among different payers and different plans to allow Americans to purchase the kind of coverage that they want to have.
But when you eliminate the ACA's Medicaid expansion, you've limited the amount of local control that those states have. You've done it in my state. In my state, we have roughly 500,000 people out of a little over 4 million people covered under Medicaid expansion alone, another 800,000 covered by regular Medicaid. So I'm wondering what that says to those states who are trying to do the best thing for their citizens.
I think that hopefully they would see that individuals, that they're not necessarily required to cover the same people under the Medicaid expansion, but we don't have a lot of assumptions on how states would use the block grants. We really are looking to provide more flexibilities of those. So given greater state flexibility with regard to eligibility requirements, benefits, the use of the block grant funds, we're hopeful that they're going to be able to cover their most vulnerable populations under Medicaid with the new flexibilities. And really, in whichever state it is, Kentucky or Arkansas or otherwise, that they'd be able to fashion this and really achieve the ultimate goal that Medicaid was originally set out to be, which is a state, federal directed program with flexibilities to allow the states to fashion it for their own populations.
Right. Is there anything in the Medicaid law that defines it as a job program?
It is not a, I don't know that it's defined as a job program.
Well, we're fighting this in Kentucky because our governor is trying to impose work requirements and actually also premiums under a Section 115 waiver that basically was written by Seema Verma, the now administrator of CMS, and it was approved by her, and now it's already been, that decision has already been overturned in court once, and it's back in court again. And one of the things that we've been questioning continuously since the effort of the governor, by the way, the Section 115 waiver application specifically or explicitly says that if it's approved, 95,000 Kentuckians will lose coverage. So I think that's a pretty good indication when somebody's actually trying to get a waiver and impose a work requirement or community engagement requirement, admits that almost 100,000 people will lose coverage. You extrapolate that across the entire country, and it's going to have a considerable impact, presumably on the health care of our country. But I was wondering, do you have any data to show, you said that you don't really know about what happens, what the exact reason for 16,000 people in Arkansas is losing their coverage, but when you have taken this path, do you have any experiential reasons for saying that this is not going to be devastating for people? That, do you know, for instance, what percentage of people on Medicaid across the country are working already or would be otherwise exempt from these programs?
So when we are really looking for the states to come to us with regard to their specific populations to determine the parameters of the community engagement requirement. So we would look to Kentucky, we would look to Arkansas and the other states when they're coming forward to us to see that what works for their population in terms of the hours that they have, in terms of the other requirements of the program. So in that sense, we do monitor what we're expecting from the states to. Certainly they're going to send us information about how work is going to affect and whether it allows a transition off of the program ultimately and into the workforce, which I think many people, that's what they're trying to achieve here. We're looking at it more broadly as community engagement or as work, but I know that a lot of people, that's going to be the form that they take. And that's going to have both economic effects on them, on their community, on the workforce that's allowed to be there, and then at the end of the day, as we think, on their behavioral and their mental health as they engage with their community. And I've heard about it as I come across the country. I've heard about it many, many times. In Kentucky was one of the places where I met with a group of people with substance use disorder. And one of them said to me, that the thing about it was before I was working, I was just a patient. I was a person who was an addict. And all I did was sit at home and look for the next meeting with my doctor, the next meeting with my counselor, the next meeting with my group. When I had work, at least for 8 hours a day, people were treating me as a coworker and a colleague, and I didn't think about my addiction all the time. That took him out of himself and meant that he wasn't always an addict. And that was a huge improvement for him, for his own feeling about himself, and that has ramifications. And I think that as we see these things going forward, whether I've heard it for people with mental health issues, for people who have substance use disorders, for the disabled, that they all look to us and they say, I've heard it from each one of those groups saying, it's so important for us to have encouragement to work, for those, so that people see us not just as a disabled person, a person with a mental disorder or an addict, but as somebody who can contribute to them, who can be a coworker, a colleague, and a fellow American. So I think it's an important, I think it could be a tremendous achievement.
I don't want to abuse the power of the chair, but I would say I think that maybe makes the case for not having work requirements, because what it indicates to me is that people basically do want to work, and if they can, they will. So you don't need to put this unnecessary burden on them. But with that, I would say thank you so much, Deputy Secretary Hargan. I appreciate your testimony. And please be advised, the members can submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. Any members who wish to submit questions for the record may do so within 7 days. Once again, thank you, and with that, without objection, this hearing is adjourned.